we can mute it here if we need to during the...
I don't know where Vic's gone.
Maybe just mute it first.
Good afternoon, everybody. Welcome, and thank you so much for coming into a beautifully air-conditioned building. Hello, World Wide Web. You are out there. That was really freaky. Okay. Clive, make it stop. Now I've gone red. Okay, hello, my name's Olivia Butterworth. I'm Head of Public Voice at NHS England and I suppose the sponsoring team for the development of this thing that we're creating called NHS Citizen. Some of you have been involved in this since July time and perhaps earlier last year. Some of you, this will be your first experience of it today. It's a work in progress. It's a work in creation about how we genuinely create a space and create a means through which citizens can hold NHS England to account in a constructive dialogue around improving our health and care services. It's really exciting. And today, I'm not going to tell you what we're going to do today. Catherine and Anthony are going to do that in detail. But today feels like the first time we've got something to sort of show and tell. Something that we can say, actually, we've heard, we've listened, we've been doing this with people. This is where we've got to. If you get confused through the day, because this isn't like going to be a conference, you're going to be scattered to the four winds of the spaces we've got. The space where you sat to have lunch, Nagina, who is there at the back, waving her hands, and NASA will be around. If it's not working for you and you don't know what's going on, just go say hi to them and they'll sit and have a chat with you and help you think about where you might want to go and what you might want to do. few little housekeeping things. I'm using a microphone not because of in this room, because you should all be able to hear me. This is for our friends watching on the World Wide Web. So hello if you're watching on the World Wide Web. Thanks for joining us. We've been webcasting a lot of the workshops that we've been doing, and we've been getting great engagement from people who aren't able to get to different rooms and physically be there. But it's a really different way of being able to bring other people into the conversation. If you're tweeting, we're tweeting on hashtag NHS Citizen, and there are many people in the room, hello Access Dorset, who are here because we connected up on Twitter and did that. Yes, come join in. It's great. So there's lots of Twitterers in the room, and Nagina, again, will be able to help with some social media basics, Tara, who signed up to Twitter on Monday at a lay members event. So we got a little count-up. Can we have a tally at the end of today or tomorrow, whenever you leave, as to whether or not we've managed to get you online and digital? We've also got Lord Victor Adebowale here, who is the sort of sponsoring non-exec director for NHS England, who's just had to duck out. He'll be back in a little bit. He's wandering around. If you want to connect up with him, have a chat, please do. Because actually his views on where this is going are really interesting, and he's been part of the drive to make sure it genuinely is driven by people and not just a creation by the great and the good. Domestic stuff, we will feed you. There'll be food that appears out there at some appropriate feeding time later on this afternoon if you're staying into the evening. And there'll be drinks out there as well. It is hot. Please keep drinking water. If you need anything, can I just ask all the NHS Citizen team to stand up? Half the room stands up. So all of the people that have just stood up will be able to help you should you need anything at any point during today. I will just point out, they're not all the core NHS Citizen team, just for those purposes. If you're not part of the core NHS Citizen team, can you sit down? And could the core NHS Citizen team stand up? That's a lot fewer people. Just wanted to make that point. So that's, I think, fire exits. There isn't a fire planned. If somebody sets it on fire, we leave by the fire exits that are marked by these things here, and the hotel staff will help escort us out. That's all I need to say. Cool. Anthony.
Okay, can I just ask who has not been to one of these events before? Okay, it's quite a lot of people. So I think it's worth me saying a little bit about what NHS Citizen is designed to do. So when we say things like gather and assembly meeting, you're not scratching your head and going, oh, what are they talking about? So let's start with the purpose of NHS Citizen. You've heard Olivia say that it's about making, holding the NHS England board to account, but more generally it's about trying to find and connect the public conversation that's happening right now about the NHS and give everyone easier ways of getting their voice heard and easier ways of getting issues to the places where things can happen quickly. That might not be the NHS England board, it might be something local, it might be something regional, it might be another bit of the NHS. But NHS Citizen exists to make those routes simpler for people and to give people the opportunity to have discussions about what matters to them. Now, one of the things that, I run something called the Democratic Society. We work a lot on democracy projects. And one of the real problems with democracy is there's just so many of the public. Right? There's lots of them. And so if they have lots of issues, and if they have issues that they want to talk a lot about, hard-pressed civil servants, of whom there are actually not that many, find it very hard to engage with. So what we've tried to do with NHS Citizen is to design something which connects this very big, very active conversation that's going on about the health service with the relatively small number of people on the board and elsewhere in the NHS who are able to make things happen and make things change. So we do that in three different ways, and you'll see these three different ways reflected around this room. So one of the presentations that you'll see, repeated through the agenda over the course of the 2 days, is about Discover. And Discover is the kind of outer bit, if you like, of the NHS Citizen system. That's where you find what the conversations are that are going on, what the data is that's out there to tell you about how the NHS is doing. And in the playroom, over by where you had coffee, you can see some of the data tools that we can use to find out what's happening in the conversation, to find out what's happening in the NHS, and to try and connect those things together. That's what Discover's for. And so in the Discover sessions, you'll be able to find out about how you could take part in that, and how you can see what's going on, and what you can use it for. Gather, which is the next part of the system, which you'll be hearing about over here if you stay in this room, and we'll be talking about how you make it work. Gather is about where you can say, actually, I've looked at what the conversation is, and I think the NHS ought to be talking about this issue, my issue. And you can say that. We call it raising a flag. You know, this is what the NHS ought to be talking about. This is the thing I want to discuss. And you can collect people around you and evidence around the issue so that you can have a better discussion and you can have a more joined-up discussion that isn't just you feeling frustrated about something. It's about you feeling frustrated about something and finding other people who know about it or other people who feel frustrated about it and joining all of that conversation together. And Gather is meant to be something that's positive and that's purposeful. That doesn't mean you can't say bad things, but it means that you have to come to it with a mindset that you're trying to find a solution. And so the evidence is there and the other people are there to try to work out what the NHS can do about it. Because NHS Citizen is called NHS Citizen, not NHS Consumer. It's about being an actor in the system yourself, and about doing something yourself. So Gather is designed to take you through a process that puts the evidence and the other people into the space, lets you have a good discussion, and then lets you come up with some recommendations that can go out into the NHS, and can go out into the NHS not in the spirit of, why aren't you doing this? But in the spirit of, here's how we think it can be better. And that's one of the things that we are looking to the NHS to say, well, we'll respond in an equally positive way, and we'll definitely get back to you and say what we think about it, and we'll take action if we think action is appropriate, and we'll always keep you informed. So that's one of the purposes of the Assembly meeting as well. The Assembly meeting, which is the big set-piece event that we intend to happen every 6 months, is something that is designed to bring some of the biggest, most nationally significant issues together and have a good quality discussion about them with the board there. Not sitting on a stage with their arms folded listening or being shouted at, but actually part of the discussion. And one of the things that we'll be talking about on the tables and in the discussions here is how could that work? How could it work with the technology to make sure that you can do it from wherever you are? You don't have to be in London or in Bristol or wherever. But also, how can it work in terms of taking all of the many issues that people will raise in Gather and finding the right ones to go to the Assembly without letting the board cherry-pick just the stuff they think is easy. So I think those are the sorts of ways in which NHS Citizen works, but the most important thing about it, and the thing that underpins it all, is a cultural and attitude change. Not because we think that culture and attitude has to change and we're just being, wagging our fingers at the NHS and saying, be different. But because actually the way in which people want to interact with public services has changed. Doctor doesn't know best anymore, and bureaucrat definitely doesn't know best. So one of the things that we're trying to work with the Tavistock Institute on, one of the partners on NHS Citizen, are therefore making this attitude shift happen, making this culture shift happen, and trying to understand what the human relations elements are that will make us have a better conversation in NHS Citizen, but also make the NHS more ready to listen. So those are the different things you can explore over the course of the day. And I'm going to hand over to Catherine, who can tell you how to do it.
Excellent. So I'm Catherine Howe, and I'm from Public Eye, and there's a lot of my team here today, and we've been building some of the actual stuff that you'll be seeing. So hands up who found that whole NHS Citizen description a bit confusing. Be honest. Okay, all right. I mean, Anthony did his best. Okay, it is confusing because the thing is that we believe the NHS Citizen, when it's up and running, there's going to be a lot going on, and we also think that everybody's going to have their own experience of it. Everybody is an individual citizen in a big complicated system, and so the way we've designed this event is to try and get a sense of how that feels to people. So what we've got is the presentation spaces, which are here and here, and they're on the left-hand side. The timetable for those on the left-hand side of the programme. They're the place where you can just go and hear about one bit of the system, okay? So if you just want to sit and listen for a bit, come to the presentation spaces. There'll be time, you can ask questions and stuff, but it's much more kind of like a bit more structured. Then what we've got tables around the room where there are going to be more open discussions about particular questions that we've got. So, for instance, we don't know how we're going to figure out what issues end up going to the Assembly. There's a whole agenda setting process, which we've got some ideas about, but we want to have a much more in-depth conversation about how's that going to work. But then what we've also got is that we have actually started to prototype, and that's prototyping is a design experiment. So we've put forward one idea about how this could look and feel. And so in the UX lab round the corner, what we want is people to sit down with the team and see how close the picture that we've created is to how you want it to work. Because that's just one possible view of the future. We want to get other people's ideas about that. Now, what we've also done is that we know that data and the way in which we use data is going to be really critical. One of the exciting things about the technology is how can data help us. But that's a big and confusing and a very new area. So there's the play zone, which is the room behind the cafe, is where you can go and get a sense about actually when people are talking about big data, what do they mean? And to show you how we can maybe start to create some stories from the data and learn stuff from it. Now, going along with all of that, which maybe feels a little bit techie, is that there's going to be some of it we'll have got wrong, some of them will be spot on, I hope. So there's lots and lots going on, but we want to also talk to you as like, how does it feel, and what's the bit that we're missing? And in all of these, we're talking about, though the technology sort of dominates a bit of this event because we're actually showing you some stuff which we haven't had chance to do before. This is all, the question that has to be in all of our minds is, how does it feel to be an actual person in all of this? And also, how do we reach the people who aren't online? So that's got to go through this, but we've got to, as the humans, we've all got to bring that to the experience. So I'm expecting everybody to have a bit of a different day because nobody will do the presentation. Very few people will do the presentations all in the same order. And some people will be really interested in one aspect of it and you'll just do that and you won't care about the other bits. That is absolutely fine. So just we want you to experience what, sort of what we've built here, and then you can tell us how if it's worked for you. But what we will be doing is we're going to be asking you quite a lot of questions while you're here. I love questions. I'm a researcher. It's like, oh, this is the best event ever. Yes, loads of questions. So we'll be asking you questions in the discussions things. The presentations have got structured questions. The social reporters, the people who are going around with cameras and tweeting and stuff, they're going to be asking you questions. And we've got a survey. There's even more questions at the end. But we just want to find out from you how close, particularly for those of you who've been, it's great to have some of you who've been here with us before, but also some new faces as well. How close does this get to a vision of a future that we all want to build? So does anybody have any questions about how this is going to work? Because otherwise I'm going to set you free to go and have your own experience. I'm going to turn on the NHS Citizen machine and see what happens. Okay, so at the end of the 4 hours, we're going to gather back in here because we're a big group in this session. So we're going to gather back in here, and Camilla and Simon are going to just get some feedback from everybody, sort of back in here at the end. If at any point you want to leave, then just if you could check out with the reception desk, that would be really helpful. And as Olivia said at the beginning, if at any point you think this is all a bit much, they're working me too hard, or you just want to do something else, then the cafe is your space to use. So just don't feel obliged to be on a constant treadmill of experimentation just to please me. If someone's just staying just for the 4 hours, they go to the last.
So if someone's coming just for the afternoon, this afternoon, they go to the farewell, the shared reflection at the end of the 4 hours. If you're staying for the whole 2 days, or if you're staying for the whole day today, you go to the shared reflection at the end of your day or your 2 days. So carry on going around seeing things if you're staying for more than one 4 hour session. Does that make sense? Yeah?
Okay, so has everybody had a chance to look at the programme? Oh, sorry, yep. Oh, do you make your microphone so that your public can hear you?
What I'd like to know is what have you done since the one meeting in Exeter? Because that one was very interesting, but there was a lot of things that were taken on board. And I just wondered how far you've got with that meeting.
So ever since Exeter, so we've been building a lot of things based on the kind of feedback that we had at Exeter. So if you want to see some actual things that we've done since then, I would start in the UX room, and we can show you the stuff that we've started to create following those meetings. So all of the stuff here is showing things that we've done since we've been starting the design process. So I'd start with the guys who are going to be in the room back there if I were you. So has everyone had a chance to look at the programme? Okay, does everybody have a sense of where they want to get started looking across that year? Does everybody know where the thing they want to do is happening? Okay, so right here, right where I'm standing here, there will be Discover. I will be talking about Discover. I'm quite excited about it. Over here, will be Anthony competing with me about Gather simultaneously. You have to pick between us. No, it's harsh, isn't it? And in terms of the discussions, where's the agenda setting? Put your hands up. Agenda setting conversation.
So agenda setting is over there.
In the corner?
In that corner.
And connecting outcomes is here. So what we may do is we may ask you to move to that table, and then we're not going to have the noise pollution problem. Okay, so over there, you're now sitting... Kate, Adam, you're sitting on the... Kate, I don't know why I called you Kate. No, I thought you were Kate there. So you're having connecting outcomes, okay? That's the table there. No, making Gather work is the next session. Okay, so connecting outcomes is there, assembly is there. So who wants to, is anybody going to, well, you're going to just pick, who wants to be talking about the, what does NHS Citizen mean to you? Or do you want to have that conversation later? Okay. All right, so is anyone starting in the UX lab? Great, so you know where you're going? Yeah? Okay, and is anyone going to start in the play zone? Okay, that's probably best to work up to that one. If anybody doesn't know, come and find me as we all start moving around. So I'm pressing the start button. Go off and have experiences. Woo!
Okay, right. We're here to talk about Gather. You won't hear me amplified because this is for the webcast rather than for you. But if you do ask a question, I will give you the mic so that the World Wide Web can hear you. So, the Gather space that I was talking about a minute ago, is the place where conversations happen. So you might go and explore what the public conversation is like in Discover. You might see what people are talking about. You might come to an assembly meeting, or you might hear about the assembly meeting, and you might think, well, actually, here's what I really want to talk about. Here's what the NHS should be talking about. And the Gather space is where you can raise a flag to say, I think it should be talking about this. I think it should be talking about diabetes or EpiPens or something like that. So it works as a shared space. It works as something that is not run by a kind of big bureaucracy or a big government organisation. It's designed to be something that is self-run and self-maintained. So as far as possible, we do not want there to be thousands of staff working for the NHS supporting these kinds of discussions. We want to give you the tools, or give people the tools, to run the conversations themselves in the way that they want to. And sometimes that's offline, and sometimes that's online. And we're just going to talk you through a couple of examples of the way in which we might work a gather space. And you can go into the UX room after, or any point during these 2 days, and see what the current draft of the gather space looks like, so you can see what it looks like right now. First thing to say, like with all of NHS Citizen, this is still up for grabs. You know, there is still plenty of development to do. We're not going to get to the prototype until April, so we have time. This is just one of the Yeah? Yes, you can.
In terms of, you know, you say you're getting a prototype till April. What research has been done to identify systems and processes, procedures, technology that already exists that actually would allow you to do it? Perhaps at little or no.
Okay, so we have put out a general call, and there's a technology group that we've brought together that's open access that any technologist can come to say, you know, these are our tools. You know, so Robert, who's going to be talking to you in a minute from Citizens Foundation Iceland, has got his open source tool, Your Priorities. You'll see that we've talked to various people, and we're still open because what we're trying to do is to create a list of all of the different tools that are out there, so that we can, you know, stitch them together into the system. You know, we're not building a platform; we're building an ecosystem. So the aim is that if you have, you know, a brilliant kind of tool for one particular purpose and it works well in the NHS Citizen system, that's great. You know, you just need to follow a couple of simple kind of rules. So you need to be able to accept a MyDex login so that people can sign in with an NHS Citizen ID, and then we can push people in that tool's direction. You know, we can say this is what it's good for, use this, or if it's or use that. So it's about giving people the choice of places to have that discussion. And we have no bar on anyone in terms of the tools they bring in. It's just a question of, you know, a few simple rules just to make sure that people can log in and have a seamless experience. So that's it. But no, we're open to all of them, and as you'll see, we've designed it to be platform, you know, to be using multiple technologies. So this is an example of the sort of prototype screenshot that you'll be able to see when you get to when you go in the UX room. This actually happens to be from the Discover space. So you might imagine, for example, that you see, you know, that from the data there's a rise in GP call-outs after TV documentaries about measles. So you think, actually, you know, measles is a really important issue. MMR, take-up, you know, really, really important. So what I'd like to do is I'd like to raise a flag about measles. And so, you know, raising a flag is just to say, I think that we ought to be talking about this. And right now, you can raise a flag for the NHS England AGM, which is happening in September. So from today, from this morning, you can go online and say, I think the NHS England AGM ought to be talking about this issue, and this is why. And then we're going to try and gather some issues together and have some discussion spaces running over August to try and prepare some issues for the NHS England AGM in September. So if you want to do that, or if you want to send out a message to get people to put ideas forward, then the address is bit.ly/NHSgather. And I'll come back to that later. But so we're already trying to test this process out. And when you raise a flag, you say, well, okay, this is what I want to talk about. And then the purpose of the gather space is to try to bring together the evidence and the people around that issue. So, you know, who else wants to talk about MMR take-up, or who else wants to talk about measles? And people who've registered on the system, we will, you know, they may have said, actually, I'm interested in this, or they may have shown by the fact they've been really active in a discussion on that topic that they're interested in this. And so we can get you an audience of people who already want to have that conversation, and we will also have access to the resources of the NHS and others to bring together a library of evidence around it too. So the next stage, once you've raised your flag... Oh,
do you prioritise at that time?
No. So the aim is that every issue can be raised, and every issue has the chance to keep going through the system. It's a question of the person who raises the issue has to have the desire enough to make sure they invite people and they gather the conversation together. Because the alternative would be that we prioritise initially what conversations happen, and we support the conversations that get prioritised. But one of the problems that came up at one of our earlier workshops is that you can't necessarily easily prioritise an issue, because something that is to do with a rare condition that affects 100 people 10 people is like a massive proportion of the population that's affected by it. But something like diabetes or cancer or stroke, which has hundreds of thousands of patients, you can't use numbers, and significance is quite a sort of difficult measure to work with in an ethical way. So we think it's simpler to let every conversation have a chance, and then the ones that get the audience and the ones that get a good conversation going, they're the ones that we aim to support at.
I'm really confused about how local work that's happening locally, say with CCGs and PPI groups and our practice-based groups, there are really important stuff that's going on there, how that feeds into something like this, because it seems like all these parallel things are going on, and I still don't understand how NHS Citizen kind of works with those locality stuff that's going on.
So the question was, how does it work with local stuff, with local issues, and with existing local organisations like CCGs and patient and public involvement forums? Does this help them?
Well, I was just going to pick up that point, because patient and public involvement forums don't exist anymore. It's Health Watch, but also local patient participation groups. There are all sorts of groups. So how do you pull them all together locally?
So what we're trying to do with this, in fact what we're trying to do with all of NHS Citizen, is not create an organisation, is trying to create tools that any organisation could use. So what we're aiming to do is that in Bristol you ought to be able to say, well actually let's put the discussion through NHS Citizen, and then we'll get access to all of these useful tools and an audience that's already around Bristol that wants to have this conversation. So the idea is that if it works well, you'll get a network effect, in the same way that if you use any kind of network, you get a quicker outreach. This hopefully will give you both some really cool tools that we've tested and have good instructions on how to use, and also a ready audience of people who've been involved in the past who want to listen. And then the recommendations at the end would go to the local level rather than to the board, unless it was an issue that had national significance. That it was illustrating something that was a really big national issue. Okay, so. The next stage, once you've raised your issue and you've got your audience, is discussion and collaboration. And you'll see from the prototype in the user experience room that what we're doing here is giving people the opportunity to use different tools and different platforms, online and offline. So we'll provide offline tools so that you could host a meeting and you can report it back into the system, or you could do a mail shot, and we'll have downloadable templates and things that you can use if you want to kind of get something going offline. But we'll also have access to a set of tools for discussion that with recommendations on which works for which scenario. So I've got Robert here from the Citizens Foundation in Iceland who'll talk a little bit about his tool, which is called Your Priorities. But there are plenty of others that we're talking to. So Healthberry, I don't know if you've come across that, which is a discussion forum that's specifically about health issues. We're working with them, so their tool can be one of the ones you use. Wazoku, which is a sort of ideas generation tool, is another. And Wazoku is an interesting example of what we're trying to achieve, because sometimes people will raise an issue that is I think it's bad that the NHS does this, and it's quite a kind of issue-based conversation. But sometimes it'll be a problem-based conversation. It'll be, how can the NHS make this happen better? And Wazoku is not a discussion platform as much as an ideas platform. So you can put ideas forward and vote them up and down and think about what it takes to what it would take to make them successful. So there's lots of different ways of having the discussion, and we can show you the tools that fit that discussion best.
Link to Wazoku. So if you've got sort of campaign groups like Protect the NHS, who are very interested in anti-privatisation issues, would they go to somewhere like Wazoku to have those discussions? Because I think for me there are lots of people who are involved in campaign groups who are also users, of NHS, who have legitimate concerns, who are challenging their views through other ways, not through this sort of forum. So I'd just like some clarity on where they would sit in that scheme of things.
So the question there was, how do people who are, for example, anti-privatisation campaigners or campaign groups, how would they use this tool or any tool? And the answer is, Wazoku was specifically mentioned, but actually in general, NHS Citizen is there for every issue that you as a citizen of the NHS might want to raise. So actually, if anti-privatisation is your thing, then I'm sure you'll find people on there. But is a thing that someone is interested in, they will find that people who are interested in having that conversation on NHS Citizen and the tools that they want to use. And I would be surprised, just because it's such a big public issue, I'm not taking any view on it myself, but I'd be surprised, since it's such a big public issue, if there weren't one of the early conversations at the Assembly meeting wasn't about privatisation or financing or something like that. Now, we'll have to have a kind of process whereby you can't discuss that every single time. You have to maybe wait 2 cycles or something before you come back to it. But I would imagine it would absolutely be there, and that's fine, because that's what NHS Citizen's there for. It's there to try and draw out that public conversation in a constructive way, where people can address the issues rather than anger is good. I don't have a problem with anger, but this is about constructive.
I asked about learning earlier, learning from other experiences. The answer to the lady's question is that already exists in a number of other areas. I mean, in education, for example, we're just going into the school holidays, and parents have been fined for taking children out of school. There's an outfit called Parents Want to Say. They got 250,000 people signed a petition that they're also using the new My Involve community engagement app to actually do exactly what you're doing, is to then get the information, share the views, which then can actually be collated and passed on to the people and fed into the conversation in a collated way, because a lot of people don't want to identify themselves because they're afraid of compromising their future access to the service. And it's a really big issue. They won't actually talk to you. If that says NHS Citizen, they won't talk to you, or they will tell you what they think you want to hear rather than what they actually believe. And it's something that's come out of the research we've been doing at the University of Bath. So we can tell you a bit more about that as well.
No, I'd be really interested in hearing about that, because one of the things that we're thinking about is how we manage. People have said a lot of times, actually, I don't want to complain about the NHS because I worry that my doctor will then not treat me, or I'll be at the back of the waiting list. Is it? That is interesting. Right, sorry. For those on the webcast, we're just hearing that a local GP sacks people off his list for daring to complain. So.
Because of local growth, the GP practices are actually got their list closed. They actually can't take any more patients, and so actually they don't care.
That is interesting. And so one of the things we're thinking about is how you manage anonymisation, how you manage So since I'm picking up from your comment that you actually have a platform yourself that you'd be interested in. Brilliant. So Catherine is the leader of the tech advisory group, so she's definitely the person to talk to. Brilliant. Yeah, absolutely, and we're interested in having you in there. So that sounds great. Wazoka we've just talked about. I'm now going to hand over, to give my voice a rest, Robert from the Citizens Foundation, who will tell you a bit about your priorities, just as another example of the sort of tool that we're using.
Hey guys. So I want to tell you a little bit about your priorities and our experiences in Iceland. So we started, I'm from the Citizens Foundation, we're a non-profit. We were started in 2008, just after the financial crisis, and with the aim of giving citizens a voice in the political process. So in 2008, in Iceland and as in other places, there was not only a crash in financial terms, but it's also a crash in trust in politics. So we decided to look at what we could do on the internet and online to give people a sort of a persistent voice in the political process. Since then, we have been working a lot in Iceland, but we've also done projects in many other countries, and are active in quite a bit in Eastern Europe. We did a prototype, the first NHS Gather prototype, earlier in the year for the NHS Citizen, and I'm just going to tell you a little bit about our experiences, just for a couple of minutes. So, you see, so our first sort of big success in Iceland is a website called Better Reykjavik, and it allows people to come up with ideas on how to make Reykjavik, a better city, effectively. And people can submit ideas, they can debate ideas, and then they prioritize ideas. And the government every month takes the top ideas that have the most votes and basically discusses them and gives them a real sort of process within the city. and the ideas are usually simple. People only have about sort of 200 characters to write the idea. You can see on this, well, actually a bit vague screenshot, but the idea is at the top. But another really important element that we found is that when we launched the first version of the website, we had like regular discussions where people can write a comment and you write another comment underneath the comment, and people started to argue quite often. So what we decided to do was that we split the screen in two. So the people who are supporting the idea, they writing their points on the left side of the screen, and people who are against the idea write the comments on the right side of the screen. And this worked really well. It effectively eliminated a lot of arguments and really drew out sort of the best points why we should do something and why we should not be doing something. And people's ideas, people are also been able to vote on budget issues. And here are some photos of things that have come through as ideas, and people have chosen themselves. Those are ideas that come from people. That the city budget is being spent on specifically what people want, and in the end, citizens often have really good ideas on how to spend the money. You know, often better ideas than the bureaucrats. This is a screenshot from a website in Estonia called the People's Assembly. So the software behind the Your Priority software is open source, so anybody can download it and use it freely. So in 2012, there's a bunch of political scandals in Estonia, and the president of Estonia called out to the grassroots to come up with ideas on how to improve the political system in Estonia, and they decided to use Your Priorities, and basically about 50,000 people participated in coming up with 2,000 ideas on how to improve the political system in Estonia. This was then taken into a 300 people randomly selected assembly, and to cut a long story short, we now have two laws that actually have been approved by the Estonian parliament that came through directly from people through the Your Priorities platform. And the key there was that the president of Estonia has the power to present ideas to the Estonian parliament. And so it has had made real change. And a couple of things. This is a school in India where classes using Your Priorities to prioritize they had some free time in the schedule, and they're teaching kids about democracy by just very simple. And here again is a Bulgarian website that sort of highlights this this way of debating, which is not about arguing, but really about debating. And here's a screenshot of the original prototype of Gather that we did earlier in the year, and this is online now. You can take a look at it. It's closed for new ideas, but you can still debate ideas. I just want to point out one thing. We're working quite a bit with artificial intelligence technology at the moment, and on the right side of the screen you can see relevant news stories that sort of connect to the ideas that's been submitted by somebody. So thanks. Of course.
Sorry. When you were setting up your website, did you actually research whether people actually wanted to get involved in a conversation, or whether they were actually looking for a vehicle whereby they could just put forward their ideas and their comments to go into a general pool?
Yeah, well, we very much sort of what we like to do is we work sort of using sort of agile, sort of lean methodology. So what we did that in 2009 we launched our first website called Shadow Parliament, giving people access to commenting on law proposals, things like that, and that was actually had a lot of features and a lot of comments and like commenting features, things like that. And we actually ended up not very many people used it, so we kept on doing more and more experiments, just launching new versions of the website and trying it out until now, almost 5 years later, we are in a position where we have a system that just through experimentation and endless or so 4 or 5 cycles a year is to do things that actually people want to use.
Thank you, Robert. Can I have the clicker? Thank you kindly. When you've had your discussion in whichever way you want, on whichever platform you want, with whichever tools you want, and you can use more than one if you want to, the purpose of the discussion is to end up with something that you can take forward. So you'll see on the prototypes there is a button that says take forward, and that means I think we've discussed this enough. I want us to start putting something into the NHS system here. And once you've done that, once enough people in the discussion have said, right, okay, it's time to take this on, it's time to move on to the next stage, then there's an opportunity for people to draft a closing statement, a kind of a thing that we think we want to say to the NHS. And there could be multiple statements. It doesn't have to be just one. You don't have to agree. There isn't a kind of winner and a loser. You can draft multiple statements, and people can vote for all of the ones that they prefer. So you'll get a ranked list of what people think is the best outcome from these, or the outcome they want to recommend from the discussion for the health service as a whole, or for the bit of the local bit or whatever. And all of those statements that are voted up, all that have more yes votes than no votes, will get put to the relevant part of the NHS. And we'll be using the existing NHS structures that take things like MPs' letters and parliamentary questions to direct things to the right place where they can get answered. So the purpose then is to say, this is what's going into the NHS. Some things will go to the Assembly meeting, and you can go and talk to Simon and his team about how that works and how they select the ideas for that. But everything will get somewhere if people are going to draft a closing statement on it. And these are the questions that we want to talk about, not necessarily now, but over the course of the next 2 days and as we develop the Gather space further. First, how does it form an addressable question? As in, how do you make sure that Gather isn't just people saying something that they feel very strongly, but which doesn't necessarily have an answer or isn't necessarily something that you can make happen? Second, what are the tools that you need? What are the best selection of tools? And have we missed any kind of platforms or tools or interesting things that will help people organise around an issue or will help people discuss it? And how do we manage the accessibility? How do we manage it online and offline? How do we make sure that this isn't another platform that favours middle-class, articulate people who can use English well? How do you make all of those things work? And finally, how do we make policymakers able to work with citizens? Because the best way for the Gather space to work is if you don't just come up with your idea and send it to this faceless thing called the NHS, which then sends you back an answer. The best thing would be if the people who were involved, the policymakers, the decision makers, actually got into the space and discussed it with you. So that's one of the things that the culture change people, the human relations people are trying to work on, but it's also something that we need to work out how we can support. So those are some of our questions. Plenty of other questions, I'm sure. Now it's time. We've got a chance to discuss it.
I didn't quite catch whether you said, I didn't quite catch what safeguards there are, so that it's not, the people that speak, the most, or they rig it in some way, getting all their pals to sort of vote in or something. Are there any safeguards like that?
So we democracy activists call that astroturfing, fake grassroots. And what we've got to try and do is work out an identity system that is about genuine identity. So you can't just create a million fake identities and log in with them. So that's one of the reasons why we're using MyDex. And you can see Catherine's running a session on identity in the next session on one of those two tables at the back, so you can hear about that. The second is that we're going to try to work on a measure. So you might have seen on your priorities that they had a measure called social points. And social points are a kind of internal measure within your priorities that enables you to kind of boost your ideas up or advertise your ideas so people can vote on them. We're not exactly going to use that, but we might use a similar kind of karma system whereby you kind of build, by doing things that are rated well or doing things that are constructive, you get a slightly higher status, and that kind of guarantees that you get slightly more privileges. And if you're seen to be astroturfing or, forcing fake debates on the site, then you get pushed down. And obviously there'll be moderation against insulting comments and spam and the usual things you wouldn't want to see. Any other thoughts or questions? Yes.
I'm very interested in the one that says, can we involve all voices in these discussions? Now, I work in Bournemouth, and we've got a lot of older people there who are not online, obviously. I think at least 35%, those are the ones that come to the forum, they're not. They have no intention of getting online. And I notice you've got it under the research questions. So my question is, who researches this and what happens next? Could be a long process.
Could I add homelessness?
Yes, of course. Yeah. So there's the reason it's a research question is not because we want to commission this long research project, but it's because it's one of the things that we're thinking about right now. And the answer is we've got to try to work out how we manage an offline environment for this as well. And that's the thing about having, toolkits that people can use to have discussions, but also even if one person in that group is online, or if there's a support worker or someone who is online, we will give them a tool to report back that conversation into the space, because the discussion can happen online or offline. The only thing that you need to kind of leave is like the sort of digital artifact that this happened and this is what people talked about, almost like the minutes of a meeting. So you can write that up and put it on there, and then it would be held there as a digital archive. And you'd still then get the access to all of the routes into the NHS and all of the kind of being able to send it on to the right person. We aren't going to be precious about insisting that everyone logs in with a separate ID. It's fine for you to have that as an offline process that you then report back, and we'll then put it through the same tools. And you could do that with homeless people as well. And again, as long as there's one person in that group who's able to report back, then that's great. And even if there isn't, we're going to try and put a support network in place so that there's people to help those conversations happen in communities who might not find it easy to do. Sorry, Tilly, you're on the team.
I was just going to ask, and it relates back to the question asked earlier about when you say we've had enough chat about this, we move it on. What's the critical mass to move it on? Because you were talking earlier about we're not going to prioritise this in case there's an overrepresentation in a particular area. Well, that surely has the same issues, does it?
So what we're trying to work on is something that's in our world of jargon called the balanced scorecard, which is the idea that you can judge a quality of a discussion by how many views are expressed, how many differing views are expressed, and that you take it forward when a certain number of people who've been active in the discussion have said that it's done. So in other words, you might say not 50% of everyone who's ever taken part in the discussion, but 50% of people who've been active in the last week in that discussion have said they want to move it on. And then, that. But what we've got to try to work, the reason it's called a balanced scorecard is that it's not just about numbers, it's about quality. And how do you measure the quality of discussion? Well, one of the ways is differing views. Because if you put something up, that, I love cats, everyone's going to say, yes, I really love cats, except for one guy who says, I really hate cats. And that would be me. And so, you have that kind of unproductive discussion. What I think we're aiming for is to find a way of measuring whether something's a good quality discussion, but it's still very much experimental. So if you wanted to come and join us on the table over there to talk about making Gather work, we can talk about that in a bit more detail. Go on.
You might answer it in your question. The question I wanted to ask was, can you define what you mean by online?
I just briefly want to bring up, because obviously I'm one of the people who's going to be researching how this is going to be done. But one of the issues that I have with things happening offline is the fact that the person reporting it then becomes a gatekeeper. And what they think has happened at the event may be very different from other people. So there's an additional issue with bringing things offline to online as to who's doing that and what say they have. There's been, I've been recently researching the Brazilian health councils, and there's a heavy involvement from healthcare managers on the health councils, which are happening offline. They all happen offline, and each municipality has them. But because the health managers are there, they're heavily involved in who's chosen to be on the council, even when it's supposed to be democratically elected. So there are some additional issues with bringing things offline into online, which are, they're woollier, I think.
Yeah, I think how would I define online? I suppose I mean digitally mediated, and sometimes that's offline things like this, which are webcast and are being recorded online. So it's not a hard definition. Oh, sorry, you better.
I was just picking up on the point you made about a large number of elderly people don't like online systems. The system we've developed from the research we found was that no, they don't like using online, which in their definition is computers. That's why I asked you the question. But they'll use their mobile phones and they'll use their tablets, and the system we've developed actually allows them to do anything. And there's all sorts of new ways, operating through their television sets, telemedicine systems. There are all sorts of other ways of doing it. So that's why I think one needs to have a clear understanding of what we mean by online.
That is very true, and I think also text messaging. There's a lot of scope there. Are there any more questions? Yes.
Mine's, again, much more generic question, really. These events that you're putting on, obviously attracting certain groups and certain people, but there are loads of people I know in Bristol who work with patient citizens. I mean, they're not here, and, I'm here, but because I'm connected to the NHS world. So I suppose in terms of disseminating this message, I still feel that it's still going to be the people who are in the know. Some new people will come into it. I don't know if it's going to be broad enough to bring in that democratic sort of thing that you're aiming for. So, if you look at the audience here, you can find massive gaps, can't you?
Can I make a comment on that? I think that's important, but I think it's up to us who represent particular communities or particular groups of interest to actually ensure that that we facilitate that. So, for example, I work for NACRO, so I work with people who are offenders, ex-offenders, whatever. So I've arranged for a similar discussion to this to take place in Bristol Prison tomorrow morning. Now, I think if we're working with those groups, we bring NHS Citizen to those groups to have that discussion rather than expecting people to turn up at events like this and feel marginalised or their voice isn't as valuable. So I think it's up to us to make sure that if this is a big debate we want to happen, that we are proactive in doing that.
Yeah, that's right. Is this on that point? No, okay, so I think that's right. And we've got the prison session tomorrow. We're also doing, I think it's 3 local deep dives where we actually try to get, working with the council and with the CCG, we try and get really deep into a community. We think that we're going to do Sunderland, we think we're going to do a bit of Dorset, and we might a bit of Dorset or Essex, and then we're going to do another urban area probably, just to try to really kind of go out and see how the messages work. Yeah. Yeah. No. So we're doing what we can, but it's as you say, it's about the whole everyone getting the word out.
Yeah, I'd just like to come back to a point you made earlier, which I'm still sort of struggling with in terms of how this makes sense on a local level. I know you did answer that, but I wonder if you could say a little bit more about that in terms of if I was visiting this tool and I was interested in a particular issue, say postcode lottery, around treatments, etc. How do I practically find that debate and engage with it on a local level? How does the website get organised?
Well, the first thing to say is you should go and sit in on one of Catherine's Discover presentations, because that's part of the answer. So if you went there, I'm reluctant perhaps to steal her thunder, but she describes the thing she calls the cube of data. So if you imagine the world, all of the issues in the world spread out as a cube, and one side of them is where they are, one side is what they are, and the other side is how deep into them you are. You can kind of, the aim for her sector is for you to say, right, I'm a person interested in diabetes in Dorset, and that means you're there and you see all of the stuff that's around you on that, which might be conversations that are going on in Gather, might be bits of data that are coming in from elsewhere, might be conversations that are happening on a local website in Dorchester, all of these sorts of things that we bring in. So the aim is that you start by, the reason it's called Discover is you start by finding out what other conversations are going on the stuff you're interested in. But also if you sign up with a user identity, you can say, actually I'm in Dorset. So when someone pops up with an issue that's about Dorset, you'll be notified. Whereas if someone raises an issue in Sunderland, then you probably won't be, unless you tag the topic as well. Have I? Good. Yeah. Sorry,
it's absolutely everything. And actually, if you come from Dorset, we just started talking to Dorset Council about how we introduce it across Dorset. It only launched 6-8 weeks ago, and it's just trickling out. But it is in Bristol.
Brilliant. Any more thoughts or questions? What's the time, Tilly? Okay. Any more thoughts or questions that won't take more than 6 minutes? No? Oh, good point. Okay, thank you very much. I hope that was useful. We'll be talking about Gather in more detail over at that table in a bit, and then I'll be giving this presentation again if it was so great you want to hear it again. But otherwise, please do go and have a look. The UX room through there, you'll see the prototype that's there at the moment, and over in the flying cube of data room called the Playroom, you can actually see the data tools that we'll be using. Thank you very much. Enjoy the rest of the day.
part of the reason we need user feedback desperately is to come up with a better name for some of the bits, okay? So as I said, who was in the, you were in Discover, who else was in the Discover presentation? Okay, all right, so there's crossover, but, so there are three types of data that are in that Discover space, okay? So there's that data which is created within the system. So stuff that you actually, if you're working in Gather, you're inside the system. So you've logged in, you've created a data store, I hope, so you're in the system. Then there's stuff that's created by you but in other places. So that would be, so we looked at patient opinion in Discover. So patient opinion is another place where data is created, but it can be associated with you as an NHS citizen. And then there's this third kind of data, related data. Related data is this what we're calling the data halo. Related data, which is stuff which is really relevant to the conversations that we're happening, but hasn't been created by an NHS citizen. And so that's what we're going to talk about now. So the kind of stuff that we're talking about is, things like health benchmarking data. It might be social media conversations. It might be on blogs. It might be newspaper articles. It might be, it might be clinical data. It's anything which we feel falls under the broad category of evidence. So if you think about this as anything that helps to give us insight into something that we might want to support a flag and gather or an assembly conversation, or is simply something which NHS citizens are talking about, it's a broad church. And one of the things there's a couple of principles around this, around the data halo. One is that we are trying to build a system which is as open as possible, and that means that which is why we want to include as many kinds of data as possible, but it's also why we don't want anybody in the system knowing more than anybody else. So where we gather data together, where we collect data together, we then want to make it accessible to everybody. So what we're not trying to do is to make it easier for the NHS to gather data about us. This is a shared resource of data. So that's quite an important principle. And the other thing is, and this is the bit that when Jackie talks about some of the web science stuff that we can do, is that we're looking for opportunities to invite people in to participate. So this isn't about monitoring people or surveilling them. This is about finding conversations where they're happening and inviting people to participate. And if they don't choose to participate, that's fine. But what we're not trying to do is just loads and loads of social media monitoring so that the machine can make the decisions. This is all about finding people, inviting them in, treating people like people. So, some examples. I'm going to hand over now to some of the system partners and also then to Jackie, who's been actually building some stuff. So, you have to use the microphone for the webcast.
I will. Hello, everyone. My name is Andreas, and I work for an organization called Membership Engagement Services. We provide, as the name implies, engagement services to about 150 NHS organizations around the country, and that's both providers, so foundation trusts, and clinical commissioning groups. Some of the data that we use in order to inform and to build engagement strategies are two geodemographic segmentations, and I probably lost half of you right there when I said that, called Acorn and Wellbeing Acorn. What these really are really, really rich and complex data sets that tells you a lot about the lifestyles and behaviors and typical patterns about people, and they're linked to geographical locations. So based on a postcode, you can actually say quite a lot about the typical type of people that live in those households. And a postcode typically represents 10 to 15 households. So it will not tell you about each individual that lives there, but it will tell you sort of an overall picture of the people living there. And what can you use that for then? If you know about how people would like to be engaged with, what are typical attributes that they have that may create health risks in the future, whether they drink a lot, smoke a lot, or on the opposite, if they're really healthy. Maybe you can actually engage them in building engagement strategies that help create healthy behaviors. So there is so much data, and there's a lot. I could probably spend an hour just talking about this. So please grab me afterwards and ask questions as we go along. I'll be happy to talk more about this. The classification called Wellbeing Acorn, as the name implies, is focused on health and well-being factors. Probably one of the most important sources that goes into this is the Health Survey for England, which has been run since the early 90s. What they do is that they every year do about 8,000 household interviews to try to figure out how people live their everyday lives. I'd be happy to explain more about the other data sources if you want to, so just grab me afterwards. What this can give you is sort of a profile of different areas. And we're in Bristol today, so I did just a high-level profile of Bristol. What this is telling us is really that in this classification, there are 4 high-level groups, and then there are 25 more detailed subtypes. But if we look at the high level here, we can see that the 2 most common groups in Bristol are groups called at-risk and caution. The at-risk group represents 35.3% of the population, and caution just over 30%. And if we look at some traits or some attributes about these groups, we can see that the at-risk group have multiple unhealthy behaviors. That has to do with smoking and not eating your fruit and veg, not exercising, things like that, that will put their health at risk in the future. There are high rates of smoking, some alcohol concerns, and mental well-being is somewhat below average, and that is due to things like unemployment and death and dissatisfaction. And also you can see that obesity is above average. So that's sort of just, it gives us an idea. And we would also be able to find where in the city these people are likely to reside based on postcode data. If we look at the caution one, slightly healthier group, their health and well-being is generally good, and some behaviors may result in later ailments. There are lower levels of smoking in these areas. Alcohol consumption can exceed recommended limits, but not as much as this group. And you can see that the mental well-being is slightly higher than average. And when I say average, that means the UK average. So that is all the people that live all around the UK. So that's what you're always comparing it to. That's sort of the base population you're comparing it to. And obesity is slightly above average. So that's a quick look at the Wellbeing Acorn data. The other classification is called Acorn. This is not used perhaps as much by different NHS and health organizations. It is used by a lot of supermarkets when they plan where they should have the next Tesco or Sainsbury's. How should we actually communicate? How should we advertise and so on? But there is some data in there that is really useful for us as well. It does provide data on various demographics. It has a really rich data set on digital patterns and what people engage with digitally or not. So we're actually able to understand a little bit better who is digitally included and who is excluded. So if we have certain pockets where we know that we're not going to be able to engage with these people online, then we know we need to do something different in those areas. Once again, I'm not going to go through all of these, but grab me afterwards if you want to hear more about them. If we do look at the digital part of it, it will tell you how often people access internet, with what frequency and for how many hours. It will tell you a little bit about what they do when they are online. Do they research government services? Do they research products that they're intending to buy? It will tell you what they do with social media, if they have mobile phones, and if they use apps, and if so on, is it free apps or paid apps that they download? That might affect if we put out an app on the market, should that be a free and a paid one, and who are we likely to actually reach if we do that? There's the same thing around tablet, and then technology ownership. What sort of technology do these people own? And something that was actually added as late as last week, and which is why I made a change to my presentation about 2 hours ago, is around digital attitudes. So it's about people expressing worries about sharing personal information online and whether that is going to be secure or not. Things like feeling confident about using computers, whether they think that they can live with or without mobile internet, and their readiness sort of to adopt new technology. Are they early adopters, meaning that as soon as some new smartphone hits the market, I'm just going to buy it? Or do I prefer to wait a few years to see what other people are saying and before I feel confident in doing it? So that's a really snapshot view of Acorn and Wellbeing Acorn. And yeah, I'll be happy to answer any questions later on.
Questions at the end. So
yeah.
Jackie, over to you.
Hi, everybody. So that is what's just been presented there is what we would consider as web scientists, what the state knows about us. But as you'll see from the changes from our social web, we have 3 million of our teens unplugging from the social platforms last year because they don't want us to find out. If you want to know, you need to ask. And that's the premise that we approach it from a flying binary point of view. So the data halo for us is about engaging with those citizens directly, but using web technology to do it, which as web scientists you sort of expect. So I'm going to talk about one aspect of it right now, which is a new approach to social intelligence and how we curate and understand that conversation based on what citizens want to tell us. But in the play zone area, we've got web intelligence where we ask citizens to self-evidence what they would like us to know anonymously that will change our state view of what we think we know. So we've got an education piece in there that has changed education policy in the UK and a new lens on that whole world because we looked specifically at that cohort of 14 to 20-year-olds and what they want us to know. And interestingly, the voice of young men came through very strongly there. And we also have another piece, which is the story of open data, another part of data that the state is telling us this is what we hold on you, but what do we make of that as citizens? And we've chosen to do the social care story on that, just as it stands. We've got some very interesting views on what people might like us to add to that. And again, if any of you have any experience in that area, either in adult or in young social care, both of those things in the play zone cover that. But I'm going to focus on social intelligence now and what the citizens would like us to know about them. So the thing that we looked at is we said, well, from an NHS Citizen point of view, what do we want as the ultimate feedback? If you think of where we started this conversation in NHS Expo, what we want to know is how have we delighted you and how have we disappointed you and how can we improve? So when we looked across the social web, we came up with two topics, delight or disappoint. But in doing that, we found two other stories, and then we found a really interesting story in that as well. And as a data journalist, I'm going to share that story with you. One of the things that came across was the conversation started at NHS Expo. Fantastic, that's what we want to know. We know that it started and it continues. And patient opinion, which I don't know whether they're in the room yet, and I'd like to see, if anybody is, I'd like to talk to you. Last session. But essentially, they're curating another set of conversations that are not embedded in the main one. So that's an interesting aspect of what's actually happening. And so I'm struggling to read this. So I'm not sure. Is there anything we can do with lights here, Catherine? Just because I don't think you can see that.
Yeah, no, I think that it's a shonky.
Oh, I see. No, not that one. Four. This one. What does that do? Oh, here we go. Okay, so what this is across that landscape of are we delighting and disappointing, we're largely delighting, made a good start. Something happened on the 5th of July, so I want you to remember that because that's an important part of the NHS Citizen story. And all of this is on iPads in the play zone where you can explore it. All these buttons and things you can click and to your heart's content and tell your story of NHS Citizen. We'd be delighted to hear what you have to say. So what's happened is we've got the social platforms that are holding these conversations. Not surprisingly, we started the conversation on Twitter, so that's where it's mainly resident. And we've got buttons on this that allow us to tune Twitter out because it's skewing the conversation. But the thing that I was keen to see was we've actually started to see this beyond Twitter. That's exactly what I would expect to see because we can't curate this or we can't control it, should I say, but we can understand what's going on. So the people that already engaged with NHS Citizen are seeding this out beyond the things that we've started. Very exciting news. And essentially, those 4 topics, they're all in Twitter, but there's a mixture of what's going on across the other platforms where it's starting to seed. So again, go and explore on an iPad on the Play Zone. And here what we have is, I'm going to say, is that one? It is. I'm really struggling to read it myself, actually. Right, oh no, I won't try that. So this is about, of those conversations, we found that the top 5 of the way in which it's been amplified across the web were the key ones. There's a number on the side where you can make it 10, you can make it 2, so you can play with it yourself. But we found the top 5 were where the most of the things were going on. So if we want to understand what we need to know and how we need to engage with this, then look at the top 5. And again, in those topics that we're understanding. I know, I'm so sorry about that. So essentially these are across the various, so the last one was across the various topics in those areas, who is having what impact and what are they saying. So again, you can click through this on the iPads next door and explore that and see what they're saying. But I'll show you some of that as we go through. And then we go here and we say, okay, well, based on these 4 topics, these top 5, if you look across there, the greens, as long as you're not red-green colourblind, will tell you that generally it's a positive conversation. Again, what we evidenced on the overall data. But interestingly, what's sat in the neutral sentiment, the grey, is very, very interesting. That's something that would be worth exploring as part of the NHS Citizen project, understanding why are people neutral? And what might we do to understand what they might need to give us a positive or a negative view on things? What can we improve? What do we do well? So this is, again, where we've effectively got the key areas that we need to explore, and then we want to actually go out to the web. So not content with just telling you data. Let's go and see what they actually say. I'm hoping that this bit works. So we've said this is somebody that's an NHS whistleblower, but interestingly has a neutral opinion on what's going on. So what are they saying? These things on the right-hand side are all the snippets of the conversation. So you can run your eyes down and say, that one's interesting, what's that about? Click on it, where the grey circle is, and this is the person. And what we could do there from an NHS Citizen point of view is tell us more. Can you send us a link? Do you have some evidence? Who else might know? And we can use this to actually widen the conversation and widen the reach of what we do based on what's already there. Now, we're all NHS citizens, and actually we all come to this, not objectively, however much we might like to think that. We will all have a topic in our mind that we think is important. So is my topic in there? Is that already being talked about? If it is, great, can I engage with it? If it's not, maybe we need that topic. So viruses was there. That was just, I said to the team, what do you want to know about? They said viruses. Okay. So we looked at what was already being discussed in NHS Citizen. We looked at what that was about. And then depending on our perspective as an NHS citizen, what might we make of that? What else might we do? Who else might we connect in with that? Would we want to speak to some clinicians about that? What other data might we connect with it? But we all bring a perspective. If we bring our perspectives into the NHS Citizen system, we can explore the whole landscape. Now, this will be an organic thing. What resonates with people, where people see their start point with this, but we will start to understand the key points. That'll be perhaps where the flags are raised for gather, where we might feed that and understand that conversation for assembly. So we just thought that was a useful thing to capture the outer reaches of what might be going on. Do you remember I said to you, remember the 5th of July, something happened that day? Well, something happened that day, but the spike was at noon. That's an unusual thing for us to see. What happened? What was that about? It was about that. Because out there across the social web, there are people out there that care about this agenda. that are not connected with us in this room yet, but they're already celebrating the things that we're delighted, that the service itself delights them with. And actually, that big spike was the rise of a hashtag NHS 66, and literally a celebration across the social networks of the NHS. Now, those people, every single one of those people were prepared to put their hand up and say, I'm celebrating the NHS Day on its birthday. What if those people could be part of our NHS Citizen ecosystem? What might they contribute as well? And the idea that we were only commissioned to do this a week ago, and we already found, the outer reaches of people that care. And we're already saying, but probably have never heard of NHS Citizen. Hopefully they're hearing about it now. But probably across the web, somebody's going, oh, that's me. But ideally, that's exactly what this is about, connecting the ecosystem and bringing people on board. As a web scientist, we're working across the social web to understand the next changes that are going to help and influence the conversations, help and influence using our own digital view of what we need to be across the web and who we need to be. One of those is location, not from a point of view of where are you, I want to know where you are, but the context of I am a citizen, I am here, and therefore what I'm saying makes a difference because of where I am. So we don't have that across the social web at the moment. We have direct contracts with Twitter and we have data journalists inside Twitter that are understanding how this might work. But I just thought it would be useful to say, of the NHS citizens that are already part of this, where are they? Does that tell us anything? I mean, we also put up the spike, the happy birthday piece. We put up the topics we looked at, the people that are already influencing the conversation to contextualise this whole piece. Now, I wasn't surprised there was a cluster around London. But is it a surprise that there's one in the northwest? Is it a surprise there's one in the northeast? If we were able to do the web intelligence work that I talked about before, where we're directly dialoguing with the citizen and asking them the questions we need to ask across the web, one-to-one, might that map change? In education, it changed fundamentally, and we changed education policy as a result of that. But this is all the start of a journey, and the change that it can bring, and the understanding that, and the learning that we all need to do. The beginning of the experiment, as Catherine says. So I'll hand over to you.
Okay. Thank you. So the point of that was to give you you were very quiet. So if those of you who are in the Discover session, where were all the questions? Because you asked me loads in that. I'm obviously much more in awe of you two. So what we were trying to do there is to give you a sense of the kind of, the potential of the data which is already out there, which can be very easily gathered, and the potential then for everybody to draw that in to support the NHS Citizen system and to contribute together. And also, going back to the Health Watch question, actually, once we bring it together, this is going to be information which will be available to anybody because we're going to create this as being as open as possible. So the idea here is that, actually, sort of rather than big data being this theoretical thing that sits as an other environment, is actually how can we use this to support the thing we're trying to do? So who's got some questions about that? I can't believe you don't have questions because it's really big and complicated. So I'm going to go over there and then to Lewis. I'm going to have to give you the microphone because we're being webcast. So I know it's a kind of fake microphone because we're not amplifying.
Okay, so a lot of this is free text, just straightforward text. How is it possible to get the information from that about what people actually mean? I mean, it's, to search within that. Yes.
So it's complicated. It's data science. So some of it is natural language programming. Some of it is machine learning. Some of it is algorithms. Most of it is profiling and understanding the patterns of what people see. So this is the very beginning of the NHS Citizen journey. So this is just a week's worth of view of what it might look like. Seeing it 2 months' time, it might look very different because our data scientists, they ultimately curate this data, eyeball it, learn how these conversations happen. And the ultimate piece on this is the human piece. because the NHS is a very vibrant brand, let's say, across the social web, some of it is what we term white noise, not actually citizen speak. So we start to tune that out and put that to one side. But it's a complex set of data science techniques and goodies that we have. And on our cloud service, which is a G-Cloud service, there's what we call an intelligent platform. And all of that resides at the platform level. So a user doesn't get access to it, but the platform itself enriches everything off the social web with that intelligence. Hope that.
So do you remember when I said in the Discover, well, those of you in the Discover presentation, is that this is why the data stories we think are an important part of this, because the data web science is a very very new science, and sort of all of this sentiment analysis and all of the natural language processing, which is all the technology stuff is that it's a very, very new field, but it's growing really, really quickly. So it's really important that we have the data. We think that there's the data stories in here as well, which helps people make sense of this, but also to understand that this is just another tool to help inform the gather process, and take it into the assembly. But where previously the information was very much with the system, this is about giving the information to the participants as well, to the citizens, so that everybody has the opportunity to evidence what they're saying. Lewis, did you have a question?
So the slides you were showing were there were the data stories, but wouldn't everyone viewing those data stories take a different view from it? So how do you because it's just a load of data, how does everyone get the same story at the end of it? That's something I'm struggling with.
And I think that's a really important question. As data journalists, when we put this out to a global audience to get feedback and comment, we actually do allow comment. And so one of the things in the prototype we're showing is I want people in the UX lab to say, well, how do I interact with that as an NHS citizen? And we haven't assumed how you would like to do that, but we would like to know. And again, if you want to explore that a bit more, come into the play zone and we'll look at options there. So we have what we call data conversations actually happen when we do this as data journalists, where people interact with it, tell their own stories, and then feed that back out to the ecosystem. But we haven't built that for NHS Citizen because we haven't made that assumption. But maybe we need to.
This is the most technical end of NHS Citizen, so that I would expect people to have questions about it. So,
a couple of questions. One is in terms of gathering the data. Are you looking at, for example, lettuce pages of local papers and stuff like that to see because that might be one way that people do it. The other bit is, I was interested in your spike, and then you sort of look back to see what happened. I wondered if you'd done some more proactive stuff around if there was a local story, either good or bad, whether there had been a spike locally or nationally around that.
Yeah, so we're geospatial specialists, so for us location is everything, and you're absolutely right. One of the things I want to understand is, from an NHS citizen point of view, do I want to look at a national picture, or am I always going to contextualise it with where I happen to be, not necessarily where I live? So do we need to tell those stories? In what context do we need to set those stories? Because underneath all of that, there is, if you go into the play zone, if you happen to, as I do, live in a London borough, you can just click London boroughs and only look at it for you. Is that what you'll do? Is that what you want? So I've just, in the slideshow, only showed the national, but in the play zone, the regional picture is there. And so I want to understand what makes sense to do that. And again, if you go into the UX lab, you'll be able to play that regional picture from within the NHS system itself. So that is one of the questions we want answering, really.
Jackie, it might be a question for you. How do you? So, you've got the NHS Citizen, you've got the Discover, you've got the data stories being presented. How do you tune into something that you're interested in? How do you tune into the data story that you want?
So the 5th of July point is a good one. What happens there? So we do what we do, all the machine learning, all the stuff I described before, but we have alerts on the platform. The data scientists set something that says, tell me if these tolerances are exceeded. So the 5th of July was an alarm bell going off, going, hey, look now. And actually we saw that evolving story, and we expanded the streams as the story expanded. That's how we found hashtag NHS66. So there is an element of that where, and you can automate that, because what happens is over the first 3 months, we generally find the patterns and we automate as we go. And then where we started now is what we call a heartbeat, you know, the start of the conversation where the initial pulse is. But those buzzes are emergent, and the platform there literally is alarm bells that go off and red lights that, no, not quite red lights, but they'd love it to be red lights, but we're not doing red lights. And so literally those alarm bells go off, and then we would put a data scientist would be straight on that. So Dion has done all the work here, and she is literally listening to any alarm bells going off for what we're talking about now. So if you can tweet NHS Citizen for some of these things, she'll pick it up and see where that goes. Yeah, sure.
I think by your own rules, you need to use the microphone.
And
anyone else who wants to get a word in, you put your hand up.
And so you've got data stories or something that's emerging, and you're seeing these stories. How do you then take that story through the journey? How do you see it through the journey of NHS Citizen? Okay, so great stories, but yeah, you're just listening to that or reading that story. What can I do with that?
So the point of having the data halo is that so that we can better listen to what is going on around NHS Citizen. And when we see one of those stories emerging, the idea then is that that's then communicated back through the network as a story, so that we're not asking people to respond to the data directly. We're listening. You know, anybody who wants to, it's there. It's completely transparent. But as we find a story like "Happy Birthday NHS" or the dirty, you know, sort of my mother, you know, like loads of people have suddenly complained about dirty skirting boards in a hospital, we push that back through NHS Citizen and we bring it to people's attention. And then what we're doing is we're saying to people, this is something which you're talking about. Somebody may want to raise a flag. Somebody may want to do something about this. Or somebody might want to respond and say, actually, you're missing a bit of the story. So you found this story, but what about this thing? So data stories are the way in which we make observations about the system, but then we reflect those back into NHS Citizen, and then we ask people, we sense check them to make sure that actually, does this story resonate? Does this make sense? Is this what you're talking about? But then the idea there is to draw the people who are having the conversation into NHS Citizen, but also to draw people into, do you want to do something about it? Does that answer the question?
Yeah, just a slight follow-on. I guess the other bit is where you don't find a story. So, for example, an event happens, and then there's no activity, there's no story. I wonder whether you look at that and say, oh, why hasn't that raised issues? Yeah.
We've got 3 what we call buzz reports that we created that weren't real stories, and then there was the real story. So there were actually 4 stories evidenced during the piece of work we did, but only one of them was a real story. Other things were it just happened to be a coincidence of conversations, which when a human looks at them, goes, that's not an emergent story. Because our data journalists, who are data scientists, they know the difference. But we snapshot that buzz report in case we're wrong, so we can always go back to that. So, for example, on the education story you'll see next door, James May from Top Gear said, that's the end of science in school. And nothing happened. But we thought, well, that's an interesting thing. And then all hell let loose over the next 3 weeks. So we were able to go back to, well, that started here. And actually, that emergent story isn't the one you're seeing today. It's the one that's happened 3 weeks ago. And it was James May tweeting that out that actually made that happen. So the platform, we can capture that buzz, as we call it. But it is just a bzzz and gone. Whereas this went into an emergent story, a new hashtag was formed, 12 Noon, Twitter went mad. What was that about? That's a real story. But there are actually 4 of them, but that was the only one that was real.
Have you got another question? Oh, look, is it okay? We're going to ration him.
Well, probably this is a question maybe after. I just want to know the difference between a data scientist and a data journalist. So maybe you can tell me afterwards, actually.
I'm going to give you my interpretation is that, I mean, as a data journalist is looking for a story. If they're a good journalist, as like we would hope journalists are, then they're looking for a balanced and evidence story. But actually what they're hunting for is the narrative. What the web scientist is, like the scientist is trying to come with as neutral and as objective a view of the data as possible, and so won't present. And that's a continuum. So it's not kind of like web scientists over there, data journalists over there. There's a continuum of behaviours, and actually they're all connected. And so you can't draw a strict distinction, but a data journalist is a little bit freer to put their own interpretation on it, whereas a web scientist needs to be able to put that more objective evidence base behind it.
So I'm a web scientist and a data journalist. My CTO who's in the play zone is a data journalist and a data scientist. We would not look at the same thing in the same way. What do we do as data journalists? I would do the web science work exactly as Catherine's just said. But as a data journalist would say, hang on a minute, can a certain person say that? And what context should that sit in? And then I can build a story, but I would build an evidence story. So a journalist would build the narrative story, I would agree. But a data journalist would actually build an evidence story. But at the end of the day, we have an opinion. You know, that's the difference. A scientist would evidence that and allow people to see the rest.
I'm going to hand to Ricky because we're going to have to wind up, and I can't bear to have run 2 presentations in a row which I've failed to let him speak. Please.
So I'm just trying to think about it. I mean, if the aim of the Discover process and this process is in some sense to highlight issues which need action, and to some sense sort of highlight issues that are important for the NHS. Is there a sense in which it needs to be either comprehensive or representative of all the discourses that are happening? Because otherwise some issues are going to get privileged over others. And so I'm just wondering how you kind of get at that, like whether you're trying to be comprehensive of everything that's going on, perhaps you are, I'm not sure, or whether you're trying to be representative. And yeah, I mean, I wasn't quite sure where you were gathering your information from. Was it just Twitter, or was it lots of different sources? And then similarly, there's going to be, so for instance, you know, every GP practice has its kind of engagement process where there's going to be conversations going on offline. I mean, are they something that's trying to be captured? Are they something different that we're not trying to capture, and so on?
That's really, really good questions. Is that one of the reasons why we want to work with as many system partners as possible? Is that we want to bring in as much data into this web science so this web science piece as possible. So those GP conversations and things like that, theoretically, they could just be brought into that conversation. The reason that there's a difference between the data halo and Discover is in Discover we know who people are, and therefore we know how representative that data is. And we can't know that about the data halo, and you're right, we should expect that actually it's not representative. So the reason why we need to know who people are, which is why it's important that we gather people's identities, is so that we can then tune what we're learning from the data halo to understand whose perspective is missing from the story. And so that's why these are two, you know, because there's a lot of crossover between data halo and Discover, but actually the big difference is in Discover we know who people are, and we can make those judgments about representation then and who's missing. Does that answer your question? I think there's an issue about echo chamber of the actually the stories that you amplify are the ones that get talked about, and we're going to have to work on how do we deal with that. I'm really sorry, because I promised Susie we'd stop on time this time, because I overran last time. So we actually do have to get you all to move about. We'll be having this conversation again if you want to carry it on. I think we're having a short break, and then we're doing exactly the same thing all over again. So pick your experiences. Thank you very much.
try it. You ready?
Meet Hillary. My mum was on a hospital ward and there was no phone, so we couldn't speak. So I went on the patient opinion.
Oh, definitely.
Meet Hillary. My mum was on a hospital ward and there was no phone, so we couldn't speak. So I went on the patient opinion website and told my story.
Meet Brian. When I was diagnosed with bowel cancer, it was the nurses that helped me to accept what I was being told. I wanted to let them know what they did for me and to keep doing it for the next patient. So I...
Brilliant. So, are we a tiny little group for Discover this time? Webcasting? Excellent. Hello, the internet. We may be tiny number, but it may be that we've got thousands online. Who knows? Are we it? Come closer then, team. Let's huddle. We might as well huddle, since that let's have the luxury of a smaller conversation. Well, you want to be able to see that as well. Oh, no, yeah, huddle. They're nice, those huddle men. Okay, so, look, all of this. So this is about Discover. So Discover is kind of like, we kind of call it the soup in which everything else is floating. So Discover is the thing which connects all the conversations which are going on around the social web. Adam, come closer. Well, no, it's all right. I'm not offended. So Discover is the place that holds data and relationships and identity, so who people are, in order to be able to help us listen and learn. And so for those of you who are in the Data Halo presentation, Data Halo is about anonymous data, whereas anything that's going on in Discover, we know who's saying it. So we'll come on to that, yeah. So here's the whole NHS Citizen system. The thing is that Discover is an activity in its own right. It's people connecting to the system, but it's also where all of the data that lives, that supports Gather, that supports the assembly. So it's kind of the infrastructure.
Just really trying to understand the point you meant within Gather, that you know who's saying it. Obviously, you're going to mention patient opinion as being part of the cohort of data that you'll be accessing, but we're about anonymous patient feedback. So I guess it's more kind of you know where it's come from rather than you know who said it, maybe.
So where somebody is okay. So we'll come back to the other diagram. There are three different kinds of data that we're talking about. Stuff which is created within NHS Citizen, we will know who's created it. Stuff that is created by an NHS citizen, but it created somewhere else, we can associate it. And so what we might be able to do with patient opinion is where people say, well, I am an NHS citizen and I'm happy to have this associated, in the same way as sometimes when you authorise an app for Twitter. So I'm happy for this app to know that what I'm tweeting. No, it's only if they've got if you create an NHS citizen identity, we can associate data that you create elsewhere with that identity. And then there's the third kind of data is any other data, basically.
Is not everybody going to be an NHS citizen?
So there are two. Everybody is an NHS citizen. However, there's another sense of it, which is we need people to create a login, so to create an NHS citizen identity. Not necessarily to participate, but one of the principles for us is that we need to. One of the principles of kind of like democratic citizenship is that we know who you are. You know, in that we need to know whether or not we're talking to a representative group of people. You know, actually there needs to be a degree of accountability for what you say.
That could be a sort of, that could be an organisation, sort of making its voice felt on some particular subject. Yeah, or it could be an individual. It could be an individual within an organisation acting in their own right. Yes.
Do you have to do you have to log in with who you are and who you're representing, either yourself or an organisation? Okay.
So one of the things that when we talk about the tabletop conversation that I'm running about NHS Citizen sign-in, I want to talk to people and show some ideas about what do we need to know about people for them to participate. So I'm not covering that here, but we are having there's another session on that. So the thing is that there are basically the way that it works. So it's a very ugly diagram. Is that there's a personal data store where your data lives, and a personal data store is something. We're not creating a huge new government database. We want you to have your own store of data, and you choose to share it with us. Then there's the cloud data store, which is where we hold the data that is associated around, and then there's and everything else, and the network management system, which connects things together. So it doesn't hold any data; it holds the connections between people. It holds the network, and those are all the bits which make up NHS Citizen. And the idea is that this is a core that other people can connect to. So with patient opinion, is that patient opinion can connect to this core if they choose to. So the idea is that we're creating something which makes it easier for your citizenship to move between different platforms, because you're always an NHS citizen, and if you choose to do most of your participation on patient opinion, that's brilliant. Or if you choose to do it on a particular forum, that's also brilliant. If you choose to do it offline, that's also great. So we want people to be an NHS citizen and for that to be something that travels with them. So the different data types. The personal data store is worth kind of emphasising a little bit, because it's one of the most it's one of the newest bits of the architecture. So where usually personal data store is something which is being experimented with as a way of doing different kind of identity management. So rather than me sort of the NHS creating a system and you are creating an account on that system, the idea here is you set up a data store on an independent provider. So we're working with a social enterprise called MyDex. They have the data, and you choose, and they store it for you. You have a contract with them, and you choose to share it. So we want to have a conversation. We want to get people's feedback on this, because the idea here is it kind of rebalances the power a little bit. So it's not us holding all of your data, the system holding your data. You're choosing to share your data, which is a bit of a different message. Does that make sense?
Sorry, comparing with data.com, this is an opting-in process. Therefore, you're always going to be able to be identified. But there's another system where you could be anonymous.
Yeah. So if you participate in the data halo, and we will be listening to people who are anonymous, and it's not like they're invisible, but we think that there's an important principle, which is that actually you create a different quality of evidence if you know who people are, because you can then say, it doesn't mean that you necessarily have to publicly identify them, but if you know who people are, you can judge how representative the conversation is. So it's much easier to find out who's not there, and that's almost impossible if you work in an anonymous situation. That's one of the problems with taking online conversations into evidence, because we don't know who people are.
This may be a conversation I need to have somewhere else, but do you include proxies in the sort of entities?
So we think that the way to handle a proxy or an advocate is we want to learn from some of the people who do this around particular. There's a lot of people who have spent time thinking about this in other contexts. But we want people to be able to nominate a proxy in their data store. So they'll say, I am allowing this person to work on my behalf, so that you as an individual permission a proxy. Does that answer your question?
Yeah, the mechanics might be a bit simpler. I'm just thinking of the case with my wife where she never used email. I did her email. So she would never made the step of sort of allowing me to be her proxy. I would have allowed me to be her proxy.
Yeah, okay. So here we are in difficult marital and ethical grounds, which is that at the moment we think that you would have to have some process of permissioning someone to speak for you. Now, actually, how we do that permissioning is really interesting because obviously, it's an informed consent problem. You know, it's exactly the same set of issues as you have with informed consent. Is that how do you nominate someone to speak for you? But that's how because if this is an act of citizenship, it's really important that we don't give away the right to speak for someone else.
Yeah, it's you use a different mechanism, really, a different sort of technique. It might be a letter that's written rather than using the technology that you really want them to use. But it's sort of another medium would be used. Yeah.
Hello. I was just wondering that if you wanted somebody to act on your behalf, for example, somebody like Bristol Mind or Citizens Advice Bureau, could you use them as you could?
That's what we're imagining, yeah. Do you mind passing it back to the gentleman? Sorry.
I do a lot of stroke clubs, and people there just can't speak, or their carers are there and they tell me their stories. Now, what would that be then? Because I've got no proxy to tell their story, but they come forward to tell it because they want to be heard somehow.
I think there is a difference between a verbal story that is sort of listened to by a few people and something going permanently online. And there is a major ethical area here of getting adequate and reputable consent.
I agree. I mean, I would hope that with the situation of the carer is that you would be able to say, I'm speaking on behalf of. But I agree that I think that this is a very difficult ethical place, you know, which is how do you make it possible but safe for people to speak on behalf of other people?
So just to kind of comment on that, I work for Patient Opinion. We're a national independent patient feedback website, and when people submit stories to us, they have the option of saying who they are. So they can say a family member on behalf of someone. They can be a carer. They can be an advocate. So that we have the mechanisms to publish online anonymous online feedback and indicating kind of where it's come from, basically.
What I do is I record all the stories that I take, and then I put them back through my own computer and sort them out in story lines. But I nearly always take off the names of the people, but I've got them on the main recording. But the stories that actually go farther are anonymous.
I guess that. This is sort of getting into because one of the so in terms of looking at the whole system is that this is a mock-up at the homepage, and you can see the proper detail of this in the user experience lab. But we think that, you know, on the homepage, actually your point of entry may be any one bit of the system. So it may be that you just hit NHS Citizen, but actually a lot of people will hit it as the community. So you come in on the community tab, and the point about the carers and exactly what you're doing is that some of these people will be active and online in their own right, but other people will be connecting to offline communities. And so that's another kind of proxy, actually. So there'll be some people who will be recording, maybe they'll be doing short films, or they'll be curating stories, but they'll be bringing content from people who are offline, online, into the information space. Well, that's one of the things that we're wrestling with, whether or not, you know, is that what we need to do is we need almost a code of conduct around that, what you're doing, because I'm sure you're doing it, you know, you're doing it very ethically. Sorry, I need to, because we're webcasting it, I just need to give you the microphone back.
What I find is most people are willing to give their story, provided they've got the choice of being either anonymous or they'll put their name forward because of certain things that have happened to them in the hospitals and that, and they'd rather be anonymous afterwards.
And we certainly wouldn't want to force anybody to give their identity when they're not comfortable, and that's not the point. But I think this question of informed consent is also about the data, kind of like, these are called, in other contexts you talk about citizen journalists, people who are out creating, capturing stories about the places that they live. So we see these online, offline kind of connectors as being citizen journalists to some extent. I think you're being a citizen, you're gathering people's stories. But I think we will have to develop a code of conduct to make sure that we're not abusing anybody's trust, that actually we're presenting things in as objective a way as possible, and that what you're not doing is you're not actually using that as a mechanism for blurring the true picture. So I think it's an interesting area, and I think it's one where I think, it's going to be really vital that we work with people who are bringing the offline audience online and connecting the online and offline worlds. But that gives them quite a lot of power, actually, in the system if they're creating stories on behalf of other people. So we're going to probably have to develop some safeguards around that. And that's not an unfamiliar thing. Citizen journalism, there are lots of ethical codes around that kind of thing. There's a lot of experience we can draw on for that. But the community space in NHS Citizen is really about this network of networks, because the point of Discover is to connect things together. It's not to, we don't want to create new stuff unless there's a gap. So where possible, what we're trying to do is to find networks and conversations and groups who are already active and to join them together, not to replace them. Does that make sense? So another bit of Discover is the scary data place. So Discover is all of this data. You've got statistical data, and this is what we talked about in the Data Halo presentation. You've got statistical data, you've got lots of quantitative data, you've got big numbers about things, so lots of counting of stuff. But then you've also got more social data. What's the content? This is a tag cloud. This is actually the words that people were using around the NHS Citizen, the last few NHS Citizen events. So what kind of descriptions were people using? There's the network. So actually in Discover, there's going to be all kinds of different types of information, which is why we think that data stories are really important. Data stories are going to be something we're going to be working, getting people to show, people with the expertise to look at that data, to draw out the stories that they see within them. So here is a data story, which is there was a peak in GP referrals that coincided with a documentary about measles. And so there was, so you could actually start to show the story there, which it's not proven as a causal effect, but the story there, isn't it interesting that came on TV and this happened, this was the way the service response. How could noticing something like that help you to perhaps work with, sort of be ready for a surge in interest and stuff like that? I mean, that's a really obvious example. The example that we worked up in the last session was that to say, so, sort of somebody who's admitted to hospital, sort of puts a story on patient opinion, and Ben will talk about, he'll walk you through patient opinion in a second, puts a story on something like patient opinion anonymously to say, I was admitted to hospital, I can't believe how dirty the skirting boards were. Now, at the moment, that would just be, the way things work at the moment, that's just one story, and there's no way of anything happening with that, really. However, it would be possible with Discover to realise that actually 3,000 people talked about dirty skirting boards in this particular hospital or this particular region. Suddenly, that one experience can be shown to be a story, which is we need to look at cleaning in hospitals. And that then gets turned around into a data story. So did you know, NHS Citizen community, that actually a lot of you have been talking about dirty skirting boards? What's going on? And either people will say, well, actually, it's just people will decide it's a coincidence, or what they'll decide is to go on and raise a flag about it. So the flow through here is that Discover helps us discover things. The data stories makes observations, and what we're hoping is that we can open up that process so anybody can create a data story. And then what happens then, you move into the process of Gather, which is to do something about something that's been noticed by the system. Does that make sense?
I know that in a lot of hospitals, with regards to things like the cleaning, they have what is called place assessments and also CQC. So wouldn't things like that be picked up on those things first?
It may be that it may well be that, or it may be that the data story says you've all been noticing this, but actually, yes, CQC have also noticed it. Or it may be that the story is you've noticed it and CQC haven't noticed it. So what you can do with the story is you can put the whole picture together. Sorry. Yeah, so that should be the... Yeah, I need some water. The idea... I mean, what we're not trying to do is name and shame. So what should be perfectly possible is that actually these aren't stories which are accusatory. These are stories which are informative. Make it a long question while I got a sip of water.
Right. As anybody knows, the data and analysis can be generated or it can be manipulated by certain groups. What safeguards are you going to put in there that will stop all this data being stolen by other people or being there are some organisations that will generate their own stories and then get lots and lots of other people to add their bit because they belong to an organisation, hoping they can force it through.
So I agree, it is a challenge what you're talking about there. I can explain how we as an organisation deal with that. So patient opinion, all of our feedback is moderated by human moderators before it's published. So if we have a situation, so we track the IP address of whoever submits the story. So we've had examples where the same members of the same family were all trying to post about exactly the same thing, and in a campaigning kind of a way, and we were able to make sure that doesn't happen. So I agree, but there does need to be a human process in the middle to make sure no one is gaming it. The other thing is about feedback is I think the TripAdvisor kind of model, everybody understands it, but what it creates is a kind of pejorative view of how patient feedback or any kind of feedback mechanism works. TripAdvisor is a good way to understand the concept, but unless you've got some kind of human control over an engagement process, it is open to abuse, absolutely.
My concern is that it can be taken over by other groups, and I've seen it. But more importantly, once it's out there, it's known as the truth. And you only need some people to see it to actually turn around and go, I've seen it on the Citizen site, it must be true.
Okay, so so there's some very interesting issues in there. So the first thing is that we have to. That's really good feedback because we have to present these data stories not as facts or conclusions. We have to present these as observations. So they're not that we need to make sure that as we communicate them, they're just observations. They're not. We don't know if they're true or not. We don't know what they are. So that's a really important thing to make sure we do. In terms of that, actually politics can be argued to be a whole system of gaming the results. Politics is all about campaigning and whose opinion is going to view. And for me, the point of democracy is that you end up having the most reasonable outcome from everybody trying to get their own point of view across. So think about NHS Citizen as a democratic system where Discover is a starting point. Is that actually, if we decide to take it forward, Gather, where Tilly's talking, Gather is a much more structured information space. That's where we're going to be putting, we'll have to do more testing of the data there. Evidence will have to be demonstrated to be balanced. And then when you further go to the assembly, then you've got real people spending a lot of time interacting with the data you're putting forward. So is that I think it would be a sad, sad world if the answer came from just some data analysis. Is what the data should do is to let us get started and to start a conversation and help us learn things we didn't know before. But then it's a democratic process after that as to what do we want to do about it.
If the process is from discovery going on to Gather and the evaluation is going on in Gather to whether there is a veracity to the stories that is coming through, would there be a feedback to discovery that what that area of discussion was not valid and the reasons why it was not valid?
Yeah, so we see that everything has got to have a feedback loop. It's one of the basic principles of good engagement, but also it's just the right thing to do. So if anything sort of moves out of the process, it always has to be fed back. So things can't disappear from Gather; they have to be recommunicated back. As this, sometimes we hope that success will be actually we didn't need to take it to the assembly because we sorted it out in a conversation in Gather. So yeah, it always has to feed back, and it's really important that the outcome from the assembly gets fed back into the system as well. So yeah, that is that setting up. One of the things that digital environments should help us do better is not losing stuff, because you can set up those processes and those flows. You're not, you can make that part of the design. So a data story turns into Gather. But what we wanted to do now is just to show you this point about that's all. So that's how NHS Citizen goes inward. But what I've got is the patient opinion example. Now Ben's on his phone. He's busy. Yeah. It's all about Ben now, but he was busy on his phone. I hope he was tweeting about the presentation, don't you all? So. But we asked patient opinion have been really brilliant about wanting to work with us, because actually is that this is a complementary activity. So if you want to talk about a bit, hand over to you and then how this fits in.
Well,
and you've got sound this time.
Yeah. I think the simple thing is I've got a bit of a Ronseal thing, so you can see what it does on the tin, basically. Meet Hillary.
My mum was on a hospital ward and there was no phone, so we couldn't speak. So I went on the patient opinion website and told my story.
Meet Brian.
When I was diagnosed with bowel cancer, it was the nurses that helped me to accept what I was being told. I wanted to let them know what they did for me and to keep doing it for the next patient. So I told my story on the Patient Opinion website.
Your story comes to us at Patient Opinion. We send your story anonymously to just the right staff so that they can hear what you think. They can share it with other staff so that they keep doing the good things and change the things that need changing. Hillary told us.
The next day, the hospital put a phone for patients on my mum's ward. I think my story is rather dull. It's about phones. But I think it made a difference, not just for my mother, but for other visitors and patients in that ward.
We hear hundreds of stories from across the country. And, together, we're all making healthcare better. What's your story? Tell us about your experience of using health services at patientopinion.org.uk, or give us a call on 0800 122 3135.
I could have left you on your phone. Yeah, I mean, so the point about the patient opinion example is that patient opinion is doing an absolutely brilliant job of gathering those stories. What we're not trying to do is to substitute for that. What we want to do is to be another place where those anonymous stories can come, but also be a place where if people want to take a story further themselves, they can connect to the NHS Citizen system. And we think that there's lots of places out there like Patient Opinion, none as good, but other platforms are available. we think there are lots of places out there where people are already doing this kind of thing. We want to just be one of the places where that stuff can go as a result. Does that make sense?
Two thoughts came to mind. To what extent is Discover sort of going out to searching for the information, and to what extent is it sort of waiting for the information to come to it? And the other aspect, the other thought that's just come into my mind is, are you doing anything about complaints?
Okay, so Discover is those first two types of data. So it is data created in the system and data created by NHS citizens. The data halo, we've got another activity which is going out and hunting for stuff which is outside of NHS Citizen. What we do there is we find conversations and we invite them in. So we're being proactive with the data halo stuff, and Discover is what's there. In terms of complaints, is that we're not a complaints handling service, and we will be directing people to complaints mechanisms that already exist.
Yes, maybe it's not specific complaints. It may be types of complaints or the complaints process and how that can be improved rather than individual complaints.
Yeah, that's quite meta, actually, isn't it? So it would be perfectly appropriate to raise a flag that says, I don't think NHS England is good at handling complaints. So complaining about the complaint system is fine as long as you've got a plan for what you want to do about it. But we won't be substituting for any of the one-to-one complaints mechanisms that already exist. Gentleman over here.
Just following on from that last question, where your answer was it's outside the scope of NHS England. I mean, it might be quite useful to understand what the scope of NHS Citizen is, because quite clearly, from what I understood at the beginning, it's about creating a mirror to NHS England and its performance. There's a whole spectrum of NHS health activities that are not NHS England, and I think that's going to cause all sorts of confusion with the public about what's on and what's not.
I'll hand it back to you. Okay, so that's a really good point. The thing that we wrestle with on this is that so we're commissioned. This is a project belonging to NHS England, and we have a very specific brief, which is the board of NHS England want to be able to listen more effectively to people. That's great. The thing is that NHS England has got two different roles. So it's got its very clear statutory role, which is this is what it does, but it is also seen as the system leader as well. And so it ends up being the place where stuff about the NHS, it attracts stuff about the NHS, which may not be its responsibility, but it's definitely it's associated with it. So the way that we're planning on handling that is we think that NHS Citizen needs to catch everything, because there's no other way of building it, and actually it would be really unsatisfactory for the public if we did anything else. But what we have to be good at is directing content to the right place for the conversation. So we need to be good at directing stuff back out to CCGs or back out to, or say, actually, this is a better question for Health Watch. We need to be able to direct so where people, it's quite possible, if we're successful, that we will be the place where the conversation is spotted, but we have to be really good at routing that conversation to the place where the question can actually be answered. So it's a tension for us, but that's how we're planning on handling it. I'm just going to let Jonathan, and then back to you.
I'm just trying to get my head around to what extent you want individual NHS citizens to engage with this, and how that is balanced against the organisational interests of the sector, if you like, including the voluntary sector, and whether that NHS citizen voice might not be crowded out by the buzz that's coming from those with a vested interest in any particular health issue.
So one of the reasons, and then we'll come back to your question. So one of the reasons why I personally am so keen on the idea that you create an NHS citizen identity as an individual is so that you can recognise when the conversation is coming from those particular interest groups rather than individual citizens. And I'm quite, I mean, I don't know if we'll do it, but I'm quite interested in, so for instance, if one of the evidence tests in Gather is that you've actually had to go and check this idea with people who aren't a special interest group, so that actually one of the tests of should this go forward is actually, are there people, do uninterested parties agree that it's a good idea? So I think there's lots of ways of doing it, but...
I'm thinking of some organisations which, health watches, which in my view sometimes take forward quite safe issues, avoiding tougher meteor issues because they're trying to enjoy a relationship with their commissioners. You see what I mean? And that they'll create a lot of noise about that, but it may not really be the really gutsy stuff that people are experiencing.
I think that's and it's kind of like it echoes Stuart's point as well, is that one of the, we think it's really important that it is possible for the individual citizen to interact directly. It's why the proxy thing is important and Speaks For is important, but we can't allow people to become gatekeepers. It's a tension. But our ambition is that this is about people being able to individually act and to connect to other people. I mean, another group actually that we think need some kind of mechanism like this would be junior doctors, frontline practitioners. There are all kinds of bits of the system that are actually not helping those people actually in the situation having a voice. It's not just patients that are unprivileged like that. Yeah.
If in fact the citizen is raising problems and they go from discovery into Gather decide it's a local problem to just a specific area and communicate that to that area, I think there needs to be a feedback from that area that the problem has been resolved satisfactorily, and that's then put onto the website so that the citizen will have faith that what they're trying to say in discovery does have some meat to it and does have a result for the NHS patient's benefit.
Yeah, I think that's a really, really good point. So what we're going to try, so we sort of got a no question unanswered kind of thing. So we should be able to go back to people on everything. You shouldn't be. We don't want to lose anything in the system. Yeah, it's quite difficult because within our system, within what we're designing, we can design that in as being impossible to avoid. So we can just create. We can do the design so that there's a big space on the screen that says, look at all the things we failed to respond on. So we can create that. Where obviously there's dependencies is where the answer is coming from somewhere else. Yeah. Yes. Yeah. No, I think that's a really good point. Yeah. So, sorry.
I just feel that it's becoming more and more complicated. My vision was always that it was an opportunity to put policy changes that come through as a group from different parts of the UK. So, if you like, men don't have access to primary care whilst they're at work, and that's a policy change that we need to make. But if we haven't got phones in hospitals, that's a local issue. And I think we should kind of, because I can just see this spiralling out of control. We'll have a huge workforce doing Discover but can you see, we have to kind of, if you like, actually look at everything, take those things that are really important that we can put together as one policy and go to the board, because that's all the board does. Board sets policy, and that's what we want to change, isn't it? I think we're kind of getting into the field of individual complaints.
So that's not what's intended. So that's interesting. That's really interesting feedback. So if I just so actually Discover is where all of these conversations are going on. Gather, yeah, yeah. So so it may be so it may be men not going to see their GPs as a data story, but in terms of taking it into policy, that's the role of Gather. So actually, we'd need someone like you to say, I've seen this story, I agree this is a problem, and I'm going to take the policy forward. Yeah.
Because you're only going to get a small amount of time to actually go and present this over 2 or 3 days to the directors. So we've really got to have a good story, we've got to be powerful, and we've got to have good information and data to back it up, to twist it up their arms up their back to say, listen, you've got to listen to us. We're not bringing tittle-tattle, we're not bringing the story that appears, if you like, on Patient Opinion about some doctor that was rude to my mum. You know, I'm not being, you know what I mean? We've really got to have a powerful story to go to them and say, we need to change this policy.
Yes, we had that conversation earlier, and I've tweeted something called occupational health for SMEs as an issue. That's a policy type issue.
And if there's enough people out there that are interested in that...
Do there need to be enough people? I mean, can we not say... Can we not say it's evidently... I mean, maybe it's a small research project to work out what's going to be the cost impact of getting better occupational health support for SMEs. You know, I mean, it's not... I mean, that's an activity in Discover, because we need to discover the costs, the implications, the facts and so forth. And then we can take it... Or is it Gather? I'm not quite sure.
There's a boundary. You know, nothing happens in isolation. So there's a boundary. There's a boundary between Discover and Gather, which is where, and we can't decide. We actually can't decide. Feedback is really valuable. Is that we can't decide if it's Discover or Gather, but it's actually on the edge, which is you say, I want to start exploring this. So maybe I'm going to start gathering data about this, and I'm going to start asking some questions. So you haven't yet decided to raise a flag, but you personally are gathering the evidence and putting stuff together. And so when we originally thought about it, we said that you had to raise a flag to do that. But now we think that one of the benefits of having your own login will be you could start to gather a story, and then you can decide whether or not you're ready to turn it into a flag.
Yeah. You have to be careful about whether we say gather or discover. We have to discover the extent of the story, and then we can, in that process, we gather the evidence, because everything's got to be evidence-based in some way, and that's the gather process.
So exactly. So we think that one of the things that you've got to figure out is how do you discover things together. So how do you make sure that you can show I am now discovering a lot of evidence about this and I want to turn it into something.
Catherine, this is a bit of a side point to all of these kind of discussions about whether Discover or Gather. I think for me, one of the key things about NHS Citizen is it's got to be clear to the citizen what its role and function is. So there are health watchers out there is PALs out there, there's all sorts of things they can access, but they need to understand, and NHS Citizen has got to be really clear on articulating their very specific role, and so people understand how it fits into what's already out there.
In that, if you can, when you have time in the UX lab, have a look at the detail of how we're presenting it, because we need feedback on that. So what we need to do is we need to make sure when you encounter NHS Citizen, it is clear this is what you've just encountered. So have a look at the detailed designs and give us some feedback on that. That will be really valuable. Okay? So I'm going to hold on to the microphone because my mistake last time was allowing a last question and then we went over time. So there's lots. We can carry on talking. It's not a problem. But this session is ended and now we're off to do something else. Have we all got an experience lined up for our next experience? Go have more experiences. I will be talking about sign-in and data stores.
David, can you hear me? It's Clive from Involve. Hi. Can we... Hi, David. We can't hear you, so let me see if we can get... We can't hear... We can't hear you at the minute, David. we can see you, but not hear you. We're trying to sort the sound out now. Do you want to say something, David?
I'll say something. Leeds United 10, Manchester United 0.
We heard something come down over the ether there. What?
1, 2, 3, 4, 5,
Yeah.
7, 8, 9, 10.
We can just about hear you. We might need to get some seats closer. Keep talking, David. Just keep repeating.
Do you want me to put some earphones on and see whether that helps? I wonder whether
Earphones would help. Yes, please.
Let's try that. I was hoping to avoid this.
Come into the circle because David's going to have to be able to see you, so we need you in the circle. Okay.
Any better?
Just say a few things, David. Not really, no.
I can hear you really loudly. Oh, hello, Simon.
That is better now. Yeah. Great. Okay.
You're not tweeting this, Simon, are you?
I'm going to take a picture. Is that all right?
Now I can't hear you.
Don't just start the test.
Yeah.
Oh.
Can you hear me? Okay, David.
No, it's coming in and out.
Okay. All right. Well, we'll make a start and we'll see how we get on. Okay. Right. Well, welcome everybody to this test of the remote participant for an assembly meeting. So let me explain what we're going to do. I'm Clive Mitchell from Involve. What we're doing here, this is going to be a test, okay? So this is a little bit different to the other sessions you've been sitting in on, where we've been having presentations and conversations around tables. This is a bit of a test of tech. And what we've got is someone sitting elsewhere in a different location. So this is David Gilbert. He's going to be taking part as a remote participant in the meeting here. So can I just quickly do introductions around the group here so that David knows who's in the room here. So I'll hand the microphone round because this is the only way that David can hear us. So,
hi, I'm Jonathan from Access Dorset.
Tony Hills, Tavistock Institute.
Hi, I'm Beth from the University of Birmingham.
Sonia Involve.
Ben, patient opinion.
So, and David, you know me, I'm Simon, but I'm actually taking notes rather than participating.
Right. Okay, thanks everybody. Right, okay, so what we're going to do here in this session is I'm going to give you a subject for a conversation. We're going to imagine that we are a bit of the assembly meeting for NHS Citizen. So we're a group of people who have come along to an assembly session for NHS Citizen, and we're having a conversation in a room at the assembly meeting, and I'll give you the subject for discussion in a moment. And we've got a remote participant who's taking place, who's taking part in the meeting, but they are in a different location. They're beaming in by video conference. And what we're aiming to do in this session here is basically test out whether it works for folk in the room and for the people outside the room, whether it works to have this sort of video conferencing discussion connection between people in a room and people outside the room. And so what we'll do is we'll have a conversation. I'll introduce it in a moment. We'll have that conversation for about sort of 20 minutes, and then we'll have a sort of an evaluation of how this has worked, whether the remote connection to someone outside the room has worked for the person outside the room and the people inside the room, and have a evaluation, if you like, of this test. So does that make sense? Any questions about about the sort of purpose of this session? Okay, right. So David, are you clear? Did that explanation make sense for you?
Yeah, I'm good.
Great, lovely, thanks. Okay, so what I'd like us to talk about, okay, so we're a meeting of the Assembly for NHS Citizen. One or two people have already been in this conversation earlier, so this will be a repeat for you. But given that what we're trying to do with NHS Citizen, one of the things we're trying to do is to create something that is very accessible to all the different members of the community to take part in this thing called NHS Citizen, one way that you can view NHS Citizen is a sort of a digital by default process. Okay, it's something which we're going to use an online platform, if you like, to create and connect people. So people will be sort of engaging with NHS Citizen through an online mechanism, amongst other means. How do we ensure that if we are using a sort of a digital by default approach to NHS Citizen, how can we ensure that we don't exclude people who aren't going to be taking place, don't wish to take place, can't take place in the online space? So if the sort of thesis, if you like, and I should have explained that is a thesis as opposed to definitely a model for NHS Citizen, if we propose NHS Citizen as a digital by default space, then how do we ensure that people who aren't who aren't comfortable with taking part in an online space, who perhaps don't have access to being online, how can they take part in productively and equally within NHS Citizen? So the question is, how can we ensure equality of access to everyone into this NHS Citizen world that might be built around an online space? Okay, so what I'd like us to do, and this is going to be slightly awkward because we're going to be having to hand the microphone around the room as we have the conversation, but have a conversation for 20 minutes or so around that subject. So how can we make sure that everyone can have equality of access into NHS Citizen? If you want to go off-piste a bit, if you want to talk about other forms of accessibility, please do, but I'm sort of posing the online-offline thing as one divide, if you like, between equality of access. If you want to talk about other means of accessibility, that's absolutely fine. And then once you've had the conversation, we'll then basically have an evaluation and work out whether this worked for us, bringing David into the conversation remotely, and whether David is able to feel part of this conversation. Okay, so just a reminder, it's a test. We're just testing whether this remote participation is going to work for everyone involved, as opposed to the nature of the conversation. Okay. Right, well, if I can just sort of kick off the conversation with the question, how do we ensure that the NHS Citizen system is something that will work for everyone in terms of accessing the system? How do we ensure that we have something that provides and enables equality of access for everyone into NHS Citizen? Would anyone like to kick off the conversation? Yep.
I think that would be very difficult. My background is computing, but I'm also... Oh, yes. Yes. My background is computing, my research background, but as a campaigner, health and mental health, I've come across lots of problems with people being excluded by things elsewhere in society, outside your project, such as libraries closing. I don't know much about poor broadband quality because I'm in Bristol, but as well as that, the cuts to legal aid, which mean that when sometimes people don't get the information that, say, they might want to complain about something, but they don't get the assistance they need, say, from going to the library and having somebody explain things to them. That advocacy is in short supply, and support workers, people aren't getting the help they need and deserve. So, yeah. Okay.
Great, thank you. So that's about supporting people to have access, giving them the advocacy and the means to be able to get access to the system. Any other thoughts about how we can create something that is accessible to all? As I say, you can talk about online-offline divide, but feel free to talk about other means, other aspects of accessibility and equality as well.
Well, I think if you're trying to ensure sort of literal equal participation of everyone, then obviously that's never going to happen. There's always going to be a situation in which some people want to participate more than other people. We can't force people to participate. I mean, if it's a case of just sort of ensuring that the conversations which go on offline are captured within an online process, then I think that's a kind of different thing from enabling everyone to equally participate, because you can get at that by connecting with other organisations who are willing to participate online, but also connect with people offline. So things like the Citizens Advice Bureau, for instance, people would obviously go there. Who might not participate online. You could connect with things like the participatory forums that GP practices have. You know, those conversations again will take place offline. But there might be one person who will be willing to kind of summarise the issues that came out and put them into an online forum and so on. So I think that would be the way that you would kind of make sure those discourses are represented, even if the people themselves are not represented.
Yeah, I'd be really worried about it, digital by default. I run a disability rights organisation, and I'd be concerned that we won't capture the views of deaf people, we won't capture the views of people who are marginalised and who often aren't represented by other organisations around them that ought to be representing their views. I think it's a really interesting challenge. We run a citizen journalism project ourselves where we train disabled people as citizen journalists and in filmmaking. And we're trying to communicate with disabled people across Dorset. And that's a huge challenge, and the only way that we can get around it is by taking the citizen journalism project into those communities ourselves actively. And I don't know how a programme of the scale that we're talking about here would ever be able to do that.
David, I'm just conscious that you're listening at the moment. Do you want to come in on the conversation yet at this stage?
Just to say, it's an incredibly self-conscious process. I'm incredibly aware of almost being at the front, and that's really tricky, but there do seem to be some advantages as well. I'm able to focus much more carefully on what people are saying, interestingly. And I suppose my question is, if the question is digital by default versus not digital by default, then I'm just for everyone. Is it worse? Is there worse potential? Is there potential for more exclusion if it's digital than the ordinary quote exclusion that happens in your experience? Because I could see as a former mental health service user that some people might be more comfortable sitting here than sitting where you are. So I just want to raise that. Are we creating a new form of exclusion, or might it actually overcome some of the other forms of exclusion? Is it better? Is it worse? What's the similarities? What about that? Especially being a technical. It's all very great.
David, the sound quality and the picture quality is not great at the minute. Let me just check with the tech people. Is there anything that you guys can do? Oh, it's broadband connection. Okay, sorry, David. Just pick up where you left off and see if the line has improved.
Everybody smiled as if they heard me, but maybe they were just laughing at me.
We did hear most of it. Yes.
Okay, well, I did ramble on a bit. I'm not surprised it got cut off.
Okay, right. So your point was, David, that just to reiterate, make sure I heard it properly. So you were concerned about introducing a new form of exclusion if we were going to go digital by default. Is that the sort of? Was there anything else you wanted to add to that?
No, it's not a concern. It's a question. It's a question of what are the similarities and differences between exclusion, the ordinary exclusion that happens for people, and that which might happen if you switch to digital default. I don't have a concern one way or the other. It's a question.
Right, great. Thank you. Okay. Anyone else like to? Dion?
suppose the thing that's coming up for me is how one kind of meshes together the digital discussions and the real life ones, the virtual and the real. So if you've got your network of small groups and discussions going on, which are incredibly resource intensive. I mean, it'd be really expensive for any organisation to promote that. So it has to be connecting all these other groups that are already sort of real life discussions going on. So it's like that. And what thoughts you've had so far about linking together those offline conversations on online conversations, or the network? You know, is there a way of network mapping within NHS Citizen?
It's certainly something that we are acutely aware of, that how we make the connection between the digital world, if you like, the online world and the offline world, and we recognise that some folk won't want to or can't, or it's difficult, or there are all sorts of issues that make it difficult. Simon, do you have any comments to add about how we are responding to that within this system in terms of bringing in offline groups and organisations into the online space? So we're talking about, I suppose, about the sort of discover and gather spaces, which will be online connections. What sort of connections we're making between the offline and online there?
Hi, David. I guess the Gather is one of the very particular places where that might happen. It's the place where the issues will get generated. And the idea is that Gather could happen almost exclusively offline. It could happen at a Senate, a Citizen Senate, for example, in the southeast. And you only need one person connected to a computer to be able to upload the outcome of the conversation and the evidence and who was there, for it then to become part of the Gather process. So although there are 7 million people digitally excluded and with other forms of exclusion too, many of them will be connected to networks that then can bring it back into the system. So it doesn't necessarily need to rely on everybody. You can only contribute if you're digitally included. You will have networks where you might be able to, and then the challenge is communicating that it's available. And so, which does raise a question for me: are we going to rely on digital communication in order to get the message out? And that's what we're doing at the moment. So that is a big problem, actually.
Yeah.
I suppose I was almost thinking like there are two models. One is there is the online version with these feelers out into another bigger community that's offline, or there could be a parallel offline network parallel to an online network, and and then you've got to build the bridge between the two.
Okay, any other thoughts, reflections? Yep, Peter?
Yeah, I think that bridge very good links to service user groups of all kinds. So yes, like Health Watch, but also ones that people organise for themselves. So yes.
Yeah, and some of the examples that Jonathan talked about in terms of your network, for example, all the different ways.
My view is this is so critical to get it right. You need to consult further than this discussion, and carry out a thorough equality impact assessment of the way you market this and involve and engage people ongoing.
Yeah, that's a very interesting point, because we've in part of the sort of design workshops and events we've run so far. So, for example, at the Leeds design event, we had an organisation called Change People who support and advocate on behalf of people with learning disabilities, and they played a very big part actually in the design and the operation of the event that we ran at Leeds, and they helped to sort of support it, and they prepared materials for the events, etc. But that sort of connection that we made was a little bit happenstance. We knew about them already, and so we made connection with them. It's a challenge to us, I suppose, to make sure that we sort of understand this a little bit more systematically, that we understand the range of diversity. I'm not sure that we've got that sort of picture at the moment. Any other reflections?
Well, just picking up on what David said earlier, I mean, this is obviously a really important issue and needs to be dealt with sensitively and correctly, but there's also a sense in which you wouldn't want this to not happen because you couldn't get it perfectly right. I mean, I think what David was saying was that, there's a sense in which is what we're doing now better than what's being done before? And if it's better than what's being done before, even if it's not perfect, then it's perhaps still worth going ahead with and you can improve and so on. And to me, it seems like there's not really something that exists like this already. So it's still, even if it doesn't get it perfect straight away, it's still providing a new avenue which isn't available at the moment. So it could be reducing exclusion whilst not like solving the complete problem. So.
Yeah, that's a really good reflection because this will sort of iterate and develop and reflect and evaluate and grow and change and maybe change radically over time if it's not working in the right way. David, you've gone very still. I don't know whether you can still hear us, but the connection seems to have gone. Have we lost him altogether? Or we'll try and get you back, David. Oh, okay. Let's just take a 2-minute pause, see if we can get David back, because we do want him to be part of this conversation and discussion. So, David, hi. Hi, did you continue to hear us, or?
I lost it for the last 3 to 4 minutes.
Oh.
So when the gentleman in the beard in the middle picked up the microphone, I lost it. Not. You know what I mean.
Yes, yeah. You haven't lost it. You've lost it. Okay. Well, welcome back. So I don't know whether you caught Ricky's last point, but Ricky, if I can paraphrase, you were saying that we don't. This isn't about getting something sort of perfect now. We're going to create something that is as good as we can make it at the moment, and then we'll sort of learn and develop as we go. In terms of this thing called NHS Citizen. Do you want to come back in at all, David, with any reflections or comments?
Yes, I think I'd agree with that, because you can't. I mean, some of us in the user movement, I think, could get guilty in the past of having to have everything perfect that's not perfect. And if you're going to try something different, it's worth going for it if you've got people you trust who you're working with. So what's the phrase? Don't make perfection the enemy of good enough, or something. I think the interesting question for me sitting here is if you can get the technology better. There are 2 questions. Can you get the technology right? If you can get it right, is there still potential for a form of exclusion that you can do something, 2 levels of exclusion you might be talking about? That's how it feels here. I'm just sitting here thinking, if I could hear and see you better, would I still have issues about what it feels like, or not even being able to get to the technology in the first place?
Yeah, great. Well, that's a very nice segue, perhaps, into talking about how this has gone from the point of view of having a remote participant feed into the room. So that's the first reflection from David in terms of. Are you still there, David, or are you?
Yeah, no, I heard that. Yeah.
Okay, great. Yeah.
I'll put my hand up if I can't.
Okay, but you might freeze with your hand up, and we won't know whether you can. Anyway, so whilst you still look lively, we'll carry on. So your reflection was that if the tech was better, and I think that's probably my reflection, that it would have been great if the picture had been perfect and the sound had been perfect. But can I just ask other people to reflect from the room here as to how this has gone for them?
Just to say, David added to that was that once the tech was better, would he still feel excluded, or would actually is it just the tech that's excluding him, or is it the setup? And I think that's the really important bit of that.
Thanks, Simon. I think my hearing is going because I didn't really quite pick that up.
It's good, that guy.
Yeah, Will Harim.
Who is it?
Okay, so thoughts and reflections from people here as to whether how you felt about having an external remote participant contribute to the conversation here? I mean, was it a reflection around the tech for you, or was there other thoughts you had?
It's interesting for me, basically, because we actually have remote workers at Patient Opinion. So we have people in Scotland and then sometimes colleagues in London. And we have our weekly meetings via Skype. And the biggest problem is when multiple people talk at once. So I think by it, it makes it slightly stilted because you can't kind of have a normal conversation. You've got to kind of wait for each other and pass the microphone around. However, I think David's point about really being able to focus on what people are saying, I think that is absolutely crucial because although he can kind of vaguely see us, he hasn't got the distraction of other people in the room or other people in the corner talking about other things. He can just focus on what people are talking about. So I think in a way, interestingly, compared to the Twitter session before, I think this is more immediately feasible and will have value without having to have someone else kind of controlling it. The main thing is the broadband connection. That's the main challenge, I think, here.
Although you're assuming there are no distractions here. There aren't at the moment, but when the kids come in, there will be.
Okay, well, we would share in that distraction with you. So other thoughts from other people here? Okay, so Sonia and then Ricky.
Yes, I was wondering how it felt for you. Did you feel you were really part of the conversation? And how would we feel if we had more than one remote participant at one table, for instance? Would that be, how feasible would that be?
I'm a confident speaker. I'm somebody who does a lot of presentations, a lot of facilitation. So it's not a huge challenge for me. It might be for other people. It's disconcerting to sit at the front and for you to be facing me. So I'm very self-conscious. And my guess is for people less confident than me, that would be a problem.
Yeah, I mean, I think it's sort of, I find it quite disconcerting as well that David is at the front like he is. I mean, it feels like we're all here to talk to David, which is, rather than to talk to each other, and it did sort of take that format a little bit. I mean, we did have more to and fro with David than we did with, between ourselves. I mean, that might be mitigated if there was more than one remote person, because it would then be a bit more of a natural setup. But it would be much better if you could get people down on the same level. You know, if you're all sitting around a table or something, you've got screens at the same level, and they feel much more like participants in the room rather than one person set up slightly separate from the group.
Hang on. Great. Okay, so I'll go to Simon first. Thank you.
Well, David, it's a kind of twofold question. Do you know what the setup is? Do you know what you're being projected on? Are you aware of that? And is it kind of part of your mental map? And do you think it would feel different if you were on a tablet, kind of propped up by a chair? So you were just kind of, as Ricky says, would it feel different for you? And then for you, would it feel different for you if David was on a tablet, kind of round the table rather than on a big screen?
I'm not quite sure of your first question, Simon, but it's very obvious I'm lording it above you. You know, that does feel very much like I'm a speaker on a podium, and that is disconcerting. So I presume the answer is yes to yourself. That it would be better on a tablet. I presume you mean a digital tablet, not a tablet of stone. Yes. So yes.
Yeah, I should have explained, David. Yeah, you're on a sort of 50-inch screen TV, sort of. Yeah, you're big. You're big. Yeah. Okay, so Jonathan. Okay. Sonia.
Simon made my point, because when we were actually designing this test, I imagined the remote participant being part of the small group conversation at a table. And so I just thought about, I would think about a laptop or a tablet being there as part of a small group conversation. and perhaps having just the live cast during the plenary. And so, yeah, this setting is probably not ideal for this kind of interaction.
Yeah. So, David, so from your point of view, how would that have felt for you? I know it's a bit theoretical, but as if you had been sort of sat down at sort of eye level, and would that have got over altogether the concern about being perhaps a little bit on the spot? Is there something about the sort of person not being in the room and not being able to interact sort of dynamically with people in the room that might make them feel a little bit sort of distant or awkward or on the spot, or is the fact that you were literally, you were on display in front of us all and we were all looking round at you, was that the sort of thing that perhaps made it feel a little bit strange?
I don't know. I assume it would be easier. And what is really interesting now is looking away from people. It's really strange that the visual effort and of knowing I'm being seen disappears when I look away. I'm much more used to phone conference calls, much more used to telephone. And although you lose other things around visual, that's just something else that gives. The visual thing, the oral thing, the audible thing, the oral is really very powerful. One more thing that's interesting, and I hadn't expected. I'm now quite tired. I'm not really tired, but it's taken a lot of concentration to hold my gaze and not pick my nose or do anything else visually stupid. So there's something about maybe making it short bursts as well and not very long conversations.
Yeah. Great, yeah. So that was really helpful reflection, and there's a point there about the sort of format. So not just about bringing people down onto sort of eye level around the table, but perhaps something about the visual versus the audio format. For some people, actually might prefer to be in audio-ally rather than video-ally. Oh, okay.
That was just. It was it was something I was just thinking that giving people the option to turn off their camera at any point, but then you have to have a way of them saying they want to join the conversation again, which more than just verbally. I mean, it might be that, I don't know if there's any technology that allows them to sort of flash a light or something to say, hey, can I come back in? But I think a lot of people would probably quite like to, switch off the camera.
I was just thinking that if you did have someone small on a table, would the rest of the group forget about that person, and how would you know when you could kind of make your suggestion or your input to the conversation?
Yeah, absolutely. Yeah, that was the sort of picking up a similar point to Diane's in terms of sort of cue for coming into the conversation. Okay, David, yep, go for it.
One more. It may be a question back to you. Sorry, I've forgotten your name. How does this feel to facilitate?
Awkward, I think. But that's probably just to do, it might be to do with my facilitation, but this sort of setup, the way we've set this space up here doesn't quite work for me, because I'm sort of having to remember that you're sort of behind me, David. I'm facing the room towards the folk in the room here, and you're almost behind me. So the way we've set it up here is quite awkward. But yeah, so I suppose if we were all sat round a table, literally in one sort of circle, and you were a participant on a chair, effectively on a laptop, that might make the facilitation a bit more. I'm not sure that would sort of make the facilitation any more difficult, or I think it might make it easier. Is what I'm trying to say. I don't think. Yeah, I think that would be better from the facilitator's point of view. So I think it's probably the format that we've got here that hasn't quite worked in terms of sort of facilitating the conversation. But then, you've been able to sort of come in at various points. Either you've put your hand up or I've turned to you. So we haven't forgotten about you. We're all looking at you, but we haven't forgotten about you. Go for it.
So I think that does raise an issue, like anything, the quality of the quality of the facilitation is really important.
Yeah, absolutely.
Maybe even more important.
Yeah. So if someone's coming in remotely, then it has to be facilitated very well to make sure that they can have their sort of voice and their participation equally within the folk in the room. Yeah, Ricky wants to make a point.
I'm just sort of wondering, how this works in terms of the actual sort of NHS Citizen Assembly, which I get the impression you might need to be quite mobile in. And sort of how mobile are people who are on some sort of technology like this, which looks like it would take quite a lot of effort to move around?
Well, so my vision of this, which I think David, in his talk of it being so tiring, which was something I hadn't anticipated, was that the person would participate as a virtual participant all the way through, and essentially they'd be carried on the tablet with everybody else. So they'd go from small group to large group to small group, and so there will be plenaries where I guess you can switch off, as it were, and not be visual. But in order to be a full participant, you're going to need to be able to participate virtually for 2 days. And what you've just suggested, David, is that's actually going to be really hard. But being mobile, I'd imagined, like Sonia, it was going to be you'd be carried around. You'd be like a virtual buddy on a tablet. I thought it might be quite fun for 5 minutes.
One of the reasons I wondered as well is partly because a lot of big companies like Microsoft or IBM or even some universities have quite sophisticated like visioning suites. Where the technology is much more sophisticated and is specifically designed for doing this sort of thing. So there could be a case for using that sort of location, but then obviously it's a suite, so it's not very mobile, so people couldn't move from sort of session to session and things like that. But yeah, there's kind of, I guess there is more sophisticated technology for doing this kind of process than this. I mean, another idea might be to have a totally sort of online element to the Citizens Assembly, where anyone who wants to participate, but not actually come to the physical space, can be in a session which is totally online. Because again, there's sort of slightly more sophisticated technology which enables you to have those kind of multiple person conference calls. Just some ideas.
Yeah, there's some really good ideas. And in fact, one of the tests that we're going to be doing later today as part of these series of tests is a sort of online discussion test. We're going to give people laptops and have people in different parts of the building here having an online conversation around a topic, so it will be completely disembodied for everyone involved. Okay, so any last reflections on the test and how it felt, and whether there are things that we could think about in terms of making a remote participant involvement in the assembly sort of work better for folk, both outside and in the room? David, any last reflections from you?
Although I did say it was tiring, Simon, I think being at a conference for 2 days is pretty tiring. So it may be tiring in there's different sorts of energy going on. And money. I mean, if money were the limit, you could have fantastic technology. My guess is there'll be some decisions to be made about trade-offs there as well.
Yeah, great. Thanks, David. And any other thoughts or reflections from folk in the room? Nope. Okay, right. Well, thank you very much indeed, everyone. Thank you to David for participating and being on show and being with us throughout the session here. And thank you to everyone here in the room for your participation and contributions. Thanks, folks.
Thanks. Bye-bye. Thank you.
so we want to give people the information, but otherwise we'll be in corners talking to ourselves. Does that make anybody over there unhappy? We were going to have a conversation about outcomes. Okay, well, if you want to do that, we're not forcing people. It's just that rather than having two presentation spaces, we're going to have one presentation space. Is that okay?
Do we get to ask really more questions?
Yeah, go for it. More questions. We're talking about content. Okay, so if you haven't seen the presentation, if you want to see any of the presentations, we'll be doing that here.
Anthony, the presentation remote is just on the floor down there.
The presentation what?
Remote. There behind you. Yep.
Yeah. Thank you.
Just check it works. Great.
Yeah.
Okay, so you can do Discover. Is that actually a land or a nation?
There's several islands at the moment. Data here, given that that's on the outer rim.
No, because Jackie's, it's like the herding cats thing. Discover's up. These guys are expecting Discover. We're going to do Discover.
Is that the first one?
Good leadership. I like it.
Well, you could enter the system at any point.
Okay.
It's designed to be stumbleable upon.
So you guys ready? Okay, so can everybody hear me? I've been told not to project so well by the people on the other side of the room. So Discover is the bit that connects everything together. So it's the outer edge of the known universe of NHS Citizen. So it's the place where we bring together the data, the people, the conversations, which are going to feed into the other processes. And its purpose is to help us listen more effectively to citizens. So that's why it's there. Now, Discover is a lot of technology. And if you look at the overall system map, while it's just one aspect of the whole design, actually the Discover technology actually sits underneath a lot of the other processes to make sure that, so it joins things together. So it's infrastructure, it's the plumbing of the system. But it's also important, we're going to talk about how does Discover connect to offline spaces as well. So it's not just online, it's just it'll feel quite digital as I present it. So this is the only. It's a very rubbish slide. This is upsetting. I can see it's upsetting Lewis quite a lot. So he might have to build me another diagram overnight or something. So at the heart of NHS Citizen, there's a personal data store, which is where you store your data. So we're not creating another database, another big database owned by the state. We're creating individual citizens will hold their own data. And then there's going to be another a cloud data store, huge data store, which will hold everything else. And then there's a piece of technology which basically holds the connections between things. So that's the network that holds the network information. So those three bits make the core of NHS Citizen. Yeah. And within that core, we've got three different types of data. So there's information which is generated within the system. So a flag, all of the flag data, everything like that, so we know who they are. Then there's data that's created by NHS citizens, but somewhere else. So that might be on Twitter or on Patient Opinion. It might be so we know who they are, but they've created the information somewhere else. And then there's just related data. Now, related data is like everything that might have something to do with a flag or evidence or the NHS system generally. And that's what we're going to talk about in the Data Halo presentation. So coming back to the personal data store.
Can you go back to that slide? What's related data? What's the difference between related data and data created within
So the difference between related data and data created within NHS Citizen is data created with NHS Citizen will always be associated with an NHS Citizen. So whereas related data might be open data, it might be something which is we've listened to over using social media monitoring. Remember, we're being webcast, and I do think you're breaking your own rules by not asking a question with the microphone. I think we'll have to be back to school, Lewis.
But then, okay, so then what's the difference between related data and data created by NHS citizens in other places? Because there might not be an NHS citizen on Twitter. There might just be data. Okay.
Thank you. Thank you, Pietro. So, okay, so if we go back to the here, is that if you've created an identity, an NHS citizen identity, then you have a personal data store. But one of the things that you might have done is you might have associated that identity, that NHS citizen identity, with your Twitter login, for example. So, and the idea of writing an open system is that actually we want to enable lots of different things, lots of different bits of technology to authenticate against that login. So what that means is that because you've authenticated that platform against your identity, is that we will be able to recognise data which has been created by an NHS citizen rather than just by another. And there's a couple of we believe that's important because we think that there is a difference between data, information that we get from anonymous people and information that we get from people who we know who they are.
Just have a question about this. So somebody who's on NHS Citizen, do they have to create a login that definitely personally identifies them? So I'm just wondering whether they're allowed to have pseudonyms, for example.
So the model that we're going with at the moment, and again, this is why we're out talking to people, is that you will be able to create a pseudonym. So you don't have to be personally recognisable, but you do have to have a known identity. One of the reasons why we want to, and we're only going to, there are 4 levels of identity assurance. The final level being biometrics and kind of like, all that kind of stuff, and iris recognition and things. So we're only going to level 2. So you could, technically you could still create a fake identity within this. But what the reason there's 2 reasons why we think it's important to know who people are. There's probably 3 reasons actually. One is that actually is that in order to know who's not there, we need to know who's there. So we'll never know how representative of the general population the conversation is if we don't actually find out some stuff about people. The second thing is that we know from online community generally that people behave more constructively if there is an identity management thing there. So it's actually if you have a convention of people using their real names, people behave like civilised human beings, whereas actually anonymity is the thing that brings greatest trolling. And then the third thing is that related to that is we're trying to create a sense of community, and community is all about people. But in doing that, and this is again back to the personal data store, is that we want to do it in a way which means that you remain, as a citizen, you remain in control of the experience. So one of the ways in which we're trying to signal the fact that we're trying to do this with people, not to people, is to design around the data store idea rather than the alternative, which is to create a big old database.
Do you think that having the personal data store and actually forcing that is going to be a block to people using NHS Citizen?
Yeah, I don't know. I don't know, which is why we're getting data on that in the UX room, and why if I can persuade some people tomorrow, I want to do some in-depth run-throughs on one because I didn't have any luck with my tabletop discussion on that today. But I'm going to have another go tomorrow. Yeah, it's a big question. What's the trade-off between the kind of the extra step of creating the data store versus the benefits which we believe it brings, and we're going to have to test that with people. Just as an aside, though, is that this is a mode of identity assurance which the government is adopting more widely. It's being tested with the DVLA at the moment. There's a couple of other big trials. So actually, we may get to the point where where we're not actually the first is that actually has already created a data store and we're attaching to something that already exists, rather than we're asking people to create one for the first time.
Can I just add, I don't think necessarily that it needs to be an extra step. I mean, if it's integrated with, like MyText, for example, then it's just a question of you creating your identity and creating the data store that just comes out of that. But I still think the step of creating a new identity is probably a big barrier.
This is what this is why this is one of the things that we're testing, is that I know that one way we could do this is that we could allow people to sign in with their Twitter credentials or their Facebook credentials or things like that. There's a couple of issues with that. One is that we know that we're going to be going to a population who don't actually already have social media credentials. So doing that exclusively would exclude some people and would feel quite alien to them. But the other thing is that, and this is a design philosophy point, which is actually your citizen identity probably shouldn't be owned by someone like Facebook. As a citizen, you should own your own identity. So whether or not that's our kind of philosophical standpoint on it. The question will be, as we test it with real people, whether or not people have our high standards around citizenship or whether or not they want the convenience. We're going to have to gather the data and figure that out.
I am afraid that unless you permit, I really like the idea that people own their own identity and their own data, and with this I think that's an extra step I never thought, and I think it's absolutely critical. I think it's really good. I think if you do not give the possibility to people to have real, not pseudo, real anonymity, you will lose a group of people who have serious issues, but they are unable to speak about it because of the anonymity problem.
I think that we're going to have to keep testing on the point on anonymity. Because we want to be low, we need to be quite sustainable in terms of moderation and things like that. Is that there's a pragmatic reason why actually one of the best ways of avoiding a lot of bad behaviour is to ask people to say who they are. But you're right, there are some questions about that, whether or not even pseudonymity is enough. Yeah, so I think I think that's a very good question, and we're going to have to track it, I think. So that's so you'll have seen this if you've been through the UX experience, but you can see the idea is that, your homepage, this is just one point of entry to all of this. We've got four different, and I know these screenshots don't come up well on this screen, by the way, because apparently we need to replace the lamp and clean the filter, okay? And clean the filter. But the idea is that actually there are four different things going on with this. There's community, there's the actual people, there's discover the data-y bit, there's the gather stuff, which is where people are doing things, and there's the assembly bit, which is where you are saying how has this been interacting with the senior decision makers in the system. So if you take the community page as being a point of entry, is that actually all of the, this is all about networking networks. This is about connecting together activity which is already happening. So any of those things could be a local health watch. They could be, they could be a sort of a CCG group. They could be a patient organised group. They could be there's some really great sort of online diabetes groups and stuff like that. Or they could just be active citizens. But those people on the edges of that network, some of those will be connectors who will be bringing in the people who are offline. So, for instance, there might be a citizen journalist who works with age concern, who sees what they're volunteering in this space is making sure that some older people who don't use digital are able to be heard in the space. So while this is a digital environment, the idea is that there are people in this network who are bridging the gap between online and offline. And that is an act of citizen journalism and participation. Sorry, Lewis should sit in the front because he's always got a lot of questions.
That's fine. But so the offline, how are they mapped? And then, how is that offline process mapped? Because who's going to do that, and how's going to happen?
I like the flip there. Did you see the little flip? Yeah, extra. So network analysis, you can do network analysis in two different ways. You can approach it in two different ways. You can go in there and you can do an egocentric blitz. So you go in and you say, I want this sample of people. I'm going to ask all of them all of the questions, and suddenly you get a massive pop-up map. Highly expensive, and also it kind of tends to be a snapshot. So what we're going to do is a snowball build, which is where you find a point of entry into a group of people, you map those people, and then you ask them to pass it on. So the idea is that the mapping is a viral process. One of the things that Discover needs to be good at is constantly asking itself who's not there. So that's another reason why we want to be checking who is there, because Discover should worry about who's not there, and it should trigger, okay, we've got nobody in the 25 to 30-year-old age band at the moment, so Discover needs to go and discover those people. So that's the point. We want the community to be as inclusive as possible, and this is one of the interesting things, because lots of online community actually becomes quite homogenous. That's one of the things it does. So one of the different things we're trying to do with Discover as a community is to give it this sense of constantly looking for other people and new members.
Okay, so how do you know from that community snapshot what the demographic of the people are? How do you know that? Just by
All right. Okay, you really are going to have to move forward, because that is a bit harsh. Is that because all of these people will have created a personal data store, an NHS Citizen, so they will be NHS citizens, which means we will know what we need to know about them. So we'll have asked them. Yeah. So it's because you knew the answer to that. You're just testing me. Okay, so the actual bit of Discover that's called Discover, which we need to sort of change this a bit, is the crazy data stuff. And the crazy data stuff is we've got kind of, obviously there's going to be quantitative data, which might be health benchmarking data. It might be, all the kind of open data. It might be CQC stuff. It could be practitioner stuff. So it could actually be, it could be medical data. Anything which is available and relevant to a story within their space. But there's the network analysis, the community data, and then there's the more data, the more content-rich, what the context data, what are we talking about type stuff. We consider this to be a minority sport. So we're going to allow people, we want to enable people to interact directly with the data. We want them to have as much access as they want. There's got to be transparency about and openness. But we think that, we believe most people, this is our working assumption is most people will engage with the data via data stories, and these are going to be created by data journalists, and these will be opportunities to say, we've noticed this happening in the community. Do you agree with it? Do you think this is what's happening? And then thanks.
So I want to ask on Discover in general, is the plan to have it sort of API based design? Because I could see, that apps, in the Gather space, for example, could use, data from, like Discover through APIs. Okay, good, great.
Yeah, that's exactly the idea. So to start with is that we need to think about who can create a data story, but actually there's a relationship between the creation of a data story and the starting of a Gather conversation, which is I'm bringing together all the information around a particular topic. So you might use a data story to say, have you noticed that 3,000 people have commented on the fact there are dirty skirting boards in hospitals in the last week? Actually anything. So a data story could be instigated because something, you have noticed something in the data, and that you then use the data story to ask a question. Data stories are not answers. They're ways of helping the data be accessible so that you can answer some questions.
But the fact of raising those things have to be done by people, or can you have artificial intelligence that look at the data, and when you have something really unusual, raises a flag on that?
So we see this as a mixture of machine and human intelligence. So there's a lot that the system should learn about itself to put automated alerts in and things like that. And that's the bit. If you go into the play zone, that's where we're working. We can show the more detailed work on that. But the data stories, we think, will have that human interpretation on top of them. So it's going to be that mixture of the two. Over time, you would hope that the system learns about itself. So actually, you can be building more metrics, giving more of a health check, showing the pulse of the conversation because you learn about it. But data stories are definitely a human thing. Because it's also about how do you, so for the data one, the one that's here is bringing together data about TV viewing, or what's on a TV schedule with a spike in GP inquiries. So it turns out that there was a spike in GP referrals around for measles at the same time as there was a TV documentary about measles. And so whereas the GPs might have been experiencing that and just not having an idea, you can put the two bits of information together and help them understand a little bit better. So data stories are the much more, they're the human face of Discover. And we're thinking that this is why you need, and they're also a way, because we want people to be able to ask questions, is that this will be a route by which people can have access to analysts who can help them with it, because we think there'll be we hope it'll be a small team and of people who are able to do some of this data work. So then the other thing that Discover does is it connects to the other bits of the system. So, Discover's job is to then say, well, there's a story, what's going on? Okay, now it's time to raise a flag, and that's when we move in to gather. But it also connects to to outside of itself. So we want to just tell you about do you want to do the whole patient opinion story, including, or do you want me to? All right, Okay, yeah. So go on. So are you okay? Play his video, okay?
What we've actually got is a little animation that tells you what patient opinion does, and it'll do it more articulately than I'll ever manage. So hopefully the techie guys are going to find it for us.
Meet Hillary.
My mum was on a hospital ward and there was no phone, so we couldn't speak. So I went on the patient opinion website and told my story.
Meet Brian.
When I was diagnosed with bowel cancer, it was the nurses that helped me to accept what I was being told. I wanted to let them know what they did for me and to keep doing it for the next patient. So I told my story on the patient opinion website.
Your story comes to us at Patient Opinion. We send your story anonymously to just the right staff so that they can hear what you think. They can share it with other staff so that they keep doing the good things and change the things that need changing. Hillary told us,
the next day the hospital put a phone for patients on my mum's ward. I think my story is rather dull, it's about phones, but I think it made a difference, not just for my mother, but for other visitors and patients in that ward.
We hear hundreds of stories from across the country, and together we're all making healthcare better. What's your story? Tell us about your experience of using health services at patientopinion.org.uk or give us a call on 0800 122 3135.
So just to kind of add a little bit to that, so we're actually a not-for-profit social enterprise. We were set up by a GP 9 years ago, so we specifically exist to promote dialogue between patients and healthcare services to drive service improvement. In terms of some of the things Catherine's been saying about APIs, is we're very good at sharing our data. So we'd be able to share our data through an API key. Interestingly, part of some of the gather process about the analysis of data, we do actually have some existing reporting built in. So we apply criticality ratings to our stories, so we know what are the most serious stories. We also have themes in there, tagging what people say was good, what was bad. So I think you're talking about having kind of humans doing it and also using technology to do it. Part of what we can provide will be the technology to do that as well.
Sorry, do you want to ask Robert? Go.
So, so the technology that you use to sort of rate the stories and sort of do sentiment analysis and stuff, is that some open tech or?
No. The rating is done by human beings. Okay. So all of the stories that come onto our website are moderated. So what we do is if there's defamatory reference to specific individuals, we'd remove that. It's all about promoting safe and constructive conversations about healthcare. It's not about kind of naming and shaming people. So, and as part of the moderation process, we look at the most serious element of the story and we apply the rating on that basis.
So patient opinion for me is an example. There's a number of places which you could put in the same thing. We think patient opinion is particularly good, and also you're doing this a social care equivalent as well. So care opinion, is it care opinion? That's right. You know, so patient opinion. Firstly, it sort of shows how we want to work with system partners, because we think that's absolutely brilliant, and we shouldn't. You know, what we want to do is to amplify that and work and collaborate with it. But it also partly answers the point about anonymity as well, because that is a space where you can be anonymous and where you can be listened to by NHS Citizen without being identified. So one of the things we'll want to prototype with them is giving people the choice of your data, your story anonymously going to NHS Citizen, or the chance of you taking it yourself to NHS Citizen because you want to be more engaged. But it's an example about how the boundary, the edge of the NHS Citizen known universe can work with people who don't want to engage with us on those terms. And as I say, patient opinion, I think, is the best example of this, but I think there are other examples as well.
Yeah, I want to touch on another point, Catherine. You made a point about anonymity and vulnerable people potentially finding it difficult to share their experiences. We've actually had a lot of success in mental health, essentially because patients feel more comfortable providing anonymous feedback. And also what they often do is they use it as a way of testing out the culture of the organisation they're feeding back to. So if they get a nice, receptive and constructive response, they then often have offline conversations. So Leeds and York partnership, 50% of the feedback they receive on patient opinion leads to an offline conversation just because they respond in the right way. And it makes the service user more comfortable having that extra interaction.
Yeah, just one more quick question. Where do you see the overlap, sort of between the NHS Citizen, let's say that the story or the flag, whatever comes through patient opinion, where do you sort of look at the overlap in there?
So I think we're more about the individual patient story. I think what Catherine's talking about, NHS Citizen's role is more about aggregating the data and individual citizens looking at the data and saying, well, there's something going on here. We need to flag this up higher. I don't see NHS Citizen being about engagement on single issues or single instances of care.
Yes, wouldn't the data from the patient opinion be used as an evidence? It's part of the gathering process, so it's part of the evidence. It's not necessarily.
And I think a really important bit of the evidence. The other thing which is that there's a lovely possibility here, which is that if we end up using an individual patient's story in a data story, is that if we do this well, is you should be able to tell somebody that it wasn't just that you got a ward phone on your mother's ward. Actually, you were connected to this bigger thing, which has caused this bigger change, and that's how you build people's confidence that actually speaking up makes a difference. So that's the kind of virtuous circle that we want to create.
You said that if someone provides an anonymous feedback and then that gets accepted well, they might actually open up or something like that. How do you build that conversation with someone that is anonymous? I mean, I can see how he can come to you, but how can you go to him?
Yeah. No, so it's not patient opinion building that conversation. It's a trust responding to feedback, or a CCG or any health organisation responding to feedback about them, and they respond in a particularly constructive way. They say, here's my email address, here's my phone number. So they're opening up a separate offline conversation. And the organisations who use our service most effectively are the ones who do that in the most skillful way, essentially. Well, that's up to them, but that's their choice. And in terms of the anonymity, that's something we sit between the patient and the service, and we'd never tell the service who the patient was. So in terms of data, we have their postcode and we have their email address, but that's not something we share externally to our organisation.
Oh, you have the postcode?
Yes, and the reason we have the postcode is to make sure the relevant services or commissioners receive the feedback. So, well, if they don't share it, that's up to them. They can give a fake postcode. That's absolutely fine.
So part of the other kind of concern about Discover is making sure is that actually a digital space is shaped by the tone of the interactions as much as anything else. So one of the things, so when we're talking about the behaviours that we're signalling, is that it's very important that we've got a conscious decision about the kind of behaviour, the culture that we're trying to set there, which is where this is the connection into the human relations piece, because actually this is about a better shared culture internally and externally in the NHS. But one of the advantages of a digital space is you can give quite strong signals about behaviour in a digital space, which is less manageable in an offline space. And we know that online and offline behaviours will bleed into each other. So lots of questions about how will it be managed, about the secretariat and stuff like that. But we take the stance of wanting to do curation of content, not moderation, is that we need to trust people to behave in a civilised, in an acceptable kind of way. We can signal that, but the minute that NHS Citizen is moderating behaviour, then it stepped into a control place, which is probably not the culture we're trying to set.
I think one of the things to feed back into that conversation is that there was very, very strong support in the table discussions around Gather for moderation. That moderation was seen both as a requirement in terms of keeping it safe and healthy, but also as something that you could vary. So you could say, here's an unmoderated or less moderated space, here's a more moderated space, but also something that discouraged exclusionary behaviour, either flame wars or whatever. So I think that I see the point on curation versus moderation in Discover. I think when you're talking about stuff that's happening in Gather, we're going to have a difficult conversation about how we inherit the moderation policies of whoever we happen to be using as the platform, or whether we impose that, or whether we ask for a kind of service level agreement or moderation level agreement, or whatever you want to call it.
The other thing with moderation is it matters hugely to people who's doing the moderating. And so that's another. So there's a whole discussion around curation versus moderation to be had.
Yeah, and I just want to also to the other point in terms of anonymity or being under a full name. Like 5 years ago, I think that was true in terms of that if you're under a full name, then you behaved better. I think that's changed. I think the trolls are the convenience of logging on with Facebook. At least this in Iceland, and I'm seeing on other tech publications who use Facebook login and stuff. So many people just don't care anymore. They totally behave like dogs, even if they are totally under a full name and with their photo, unfortunately. So I think moderation. I think that's an interesting into the whole moderation discussion.
Okay, so I think that's going to have to be we need to experiment with it to zone. Okay. So, but this question about how do we want to treat each other online, we want to make some conscious decisions about saying this is how we want to treat each other online, and also how do we make sure that we're not leaving behind the offline people. So the kind of research questions, I haven't managed to get to this in either of the other two times I've done this presentation. This is quite exciting for me. Is that we've got some particular questions that we're keen on finding out more about. But there's things like the question of the data store. So actually one of the things we're interested in knowing from people is, have we demonstrated why this might be useful to you? And maybe not from this presentation, but over the course of the experiences, have we demonstrated that or not? Or actually, do people remain unconvinced? Do people feel that the data story idea is one which they can buy into? They think, yeah, that is the right way of doing that. And things like the kind of the bringing people in and connecting to other tools is the approach that we're suggesting. Does that sound like a way of connecting things together rather than just sucking up other people's content. So these are, I don't know, what would be quite nice before I hand over to Anthony to talk Gather, if I could just get people to reflect on those questions a little bit, if they're happy to. Who wants to go?
Sorry, no, you go. Well, okay, so, yeah, I think the one that I would like to pick out there is that can we connect other tools to the core? I think that maybe we need to have a bit more discussion about sort of being sort of more explicitly sort of API-centric, you know, in terms of that, you know, being sort of inviting in terms of that, you know, this is the platform. Yes, this is an app that uses the, you know, Discover and the Gather space or whatever, but it's easy, you know. You just you can, if you want to experiment in your local community with your own NHS Citizen interface, you know, that should be easy and should be sort of like something that's like at least, yeah. That was sort of my feedback on sort of one of those points.
So can you make sure you go into the play zone and have
yes,
the...
we were
yeah, okay, great, okay. Yeah.
One point I'd make is I'm not sure telling stories with data is necessarily the most useful terminology, because, well, stories is what patient opinion does. With data, what you're doing with the data is you're drawing conclusions from the data, or you're analysing the data to try and look for patterns. You're inferring things from it? Is that telling a story from it, or is that drawing a conclusion from it, or?
Okay, so can you pass to William behind it, because I'm quite. Can people comment on that, because that's a different way of seeing it to how we've seen it.
One of my aims in coming today is to have a really good shorthand for positioning patient opinion and NHS Citizen as two relative things. And what I now understand from looking at the user experience is that NHS Citizen draws on stories and a diversity of evidence and has a process for prioritising them and can take them through to sort of reasoned discussion. So I think I can see very comfortably how the two fit together. Stories are a component, one of the input components, which can be contradictory, and that's fine. The process can cope with that.
So do other people have Ben's lack of comfort with the phrase, the terminology of data story? Well, I think microphones.
Basically, yes. I mean, not uncomfortable with it in that it's the term that's in my head because we've been talking about it internally within the team. But it's a bit like one of those moments where you look at a word and you can't quite work out why it's spelt like that. You know, I'm looking at the word now with someone saying, "Oh, is that the right word?" And I'm thinking, maybe stories isn't quite right, because stories implies a plot. You know, maybe it's something that, you know, is something that is arising and bubbling up out of the data. I'm not sure what it is, but a data story implies either a piece of journalism that's been researched rather than something that's emerged, or a piece of fiction once upon a time.
So, okay, let's go to Pietro.
Yeah, I mean, I shouldn't raise this because I'm not. English is not my first language, but saying tell stories, that doesn't also mean, that something is false in some context.
I'm sorry to draw us into a debate about semantics.
It's 6:05.
But to me, just reflecting on it, and one else managed to say it on microphone rather than shouting it across the room, is it's more about themes. Because so with the data, you're seeing what's the recurring themes, really.
Okay, sorry. Well, I think we're... Good God. Okay, all right. So that's... Okay, well, we're... Okay, so we're going to do Gather here next, and then I can come and do Welcome and Sign In. Okay, I feel a little bit sad, though, because I would like to hear more about this, but I think in the interest of keeping order in chaos... So I have now noted that, and we'll probe that a little bit more. So thank you all very much indeed.
there's a huge trend towards data givebacks or data exchange. So if you're a Twitter, Google, or Facebook user, you can press a button and you can download your data. Google has a data liberation front. In America, there's a blue button, a yellow button, and a green button to download your medical data, your education data, or your energy data. So the UK government has a program aimed at industry out of BIS. So at the stroke of a pen, the Secretary of State can compel utility companies, banks, mobile phone companies to give the structured data back to the customer on demand. They've also got a program called MyGov Data, and in the NHS there's a commitment to start giving health records back by April 2015. So that's going on in the background. That's not pertinent to NHS Citizen, but that's kind of wider background about data exchange. Now, when you get that data back from those entities, it proves something quite useful. Just like in the old days, if we wanted to take out a new membership, we might use a utility bill and a bank account. If you've got digital proof you have a bank account, digital proof that you have a verified address, then this proves it, digital proof of your mobility, of your entitlement to welfare. That then feeds into another major government program run by the Cabinet Office, which is ID assurance. The assumption is that as we move to digital by default public services, you're not going to use a government ID card, which is unusable online anyway. You're going to use a third-party service to vouch for the fact that you have proper standing in the digital world. And this could be a degree, a verified address, a driving license. So the data givebacks will help the ID assurance process, and that in turn will drive more efficient digital services, because by having a personal data store to which you and only you have the key, it brings with it your login to an NHS Citizen service, your login to any service you can access by OAuth, which is like Facebook or Twitter login, OpenID, Mozilla Persona. The different ways that you log into different services and portals can all be contained in your structured personal data store. So it's a single multi-protocol way of logging in to everything. Now, the whole purpose of this is to restore the underlying basis of trust, to bring that trust to online life, which has been really badly eroded because of the services we all use. So, and I can describe how we've set up MyDex in terms of governance as a social enterprise, its commercial model, the technical model, which is very standard and open, and the legal basis of making individuals data controller. But I can go into detail on that, but everything is simply done to try and earn trust in a consistent, clear and open way. So we're really delighted that NHS Citizen wants to operate on the basis of that sort of personal data control, because we think what it does is it just kicks over to us the whole question of how you do ID and authentication for the site. If people want to express preferences for what they do and don't share with the service, we've already just got those utilities in place. You don't need to reinvent them. And if people want to store personal data or draw on personal data for any of their evidence or histories, we just handle that part of it and it's all done. Sorry? Yeah, so the way the commercial model works is this is free in perpetuity to individuals. If an organisation connects a live service to it, there's a connection fee, which is £10,000. If they want to connect batches of individuals, there's a charge of 15 pence per individual. So at volume, the ongoing cost of this is less than 4 pence per head per year. So if you're the sort of organisation that ever sends a letter to somebody, you could have bidirectional, encrypted, end-to-end connection for 10 years for the cost of one letter. So there is a charge, but in terms of the cost of running current bureaucracy, it's a massive cost reduction. So, yeah.
Do you see it? Going to grab the microphone?
Yeah.
Do you see it solving the problem of spoofed emails?
I think
spoofed emails.
I think that's not a problem we've immediately set ourselves to address. Whether or not it could, I would need to reflect about it. I did see the interesting idea that you could use Bitcoin to solve the problem of spoofed emails by dividing Bitcoins into such tiny sums of money that you wouldn't mind spending a 10,000th of a penny to send an email.
I mean, less than a stamp.
But a great deal less than a stamp, but a spammer would. I think certainly you could do permissioned peer-to-peer communications of any sort when personal standard statistics are important. We might say, as a responsible citizen of the UK, I'm happy to share certain data points, conscious that they're valuable to others, and it's no skin off my nose. That's very different from saying the NHS is welcome to give my health record to Johnson & Johnson or to Byers or someone where it's worth an incredible amount to them. And actually, it's very intimate to me. I feel rather cross about being given. And the RSS, the Royal Statistical Society, did research earlier this week saying that people are really incensed by the idea of government making money from the sale of anonymised records and of it being given to commercial businesses, surprisingly enough.
I'm going to pass this to Pietra and then back to Stuart. So I just say one of the reasons we're quite so clearly is that NHS Citizen isn't there to store patient records. But one of the things we liked about working with Moidex is that actually you could scale to do that if it worked. But it's a useful way of experimenting with the model to see whether or not it works for people. Because if this doesn't work for people, it's not going to work. But it's a lot easier to experiment around what we're doing than around the summary care record. Pietra's been really patient, and then Steve.
I'll play devil's advocate.
Welcome. Friend, I'm familiar with this role.
Exactly.
Indeed.
Now, you are of course aware that getting these to have the data.
Just thinking of a solution to that, you could almost imagine using your system as a sort of trusted third party to do the search of the data stores on behalf of the users. So you're actually asking the users.
I think.
No. Yeah.
We couldn't do the search. What we could do, there could be part of an NHS Citizen app could say, make yourself discoverable in certain circumstances, even if it's anonymous. So if you have a certain condition and you're living in a certain geographical area, you could say, I'm prepared to be discovered if other people with similar condition to me are trying a similar drug or some such thing. So Doc Searles describes this process generally as a request for service, a personal RFP, which you issue out anonymously to make yourself discoverable. So the platform would support it. We wouldn't ourselves develop it. We certainly wouldn't search our members' data because we can't see it.
For most cases, that would be okay. That would be enough.
Yeah.
For most cases, that would be enough. Of course, not for all.
Okay. So, did you have a?
No.
Okay.
Yeah.
No. Yes. No.
Isn't this smacking? Because all tomorrow they start wearing them into control, and I don't think the system should be used for doing big searches or any searches on specific types.
Okay, the aim here and the ability here won't be to do those big searches. What it will be, we won't be able to go in and proactively look for that data against people. What we will be able to do is ask questions. So we'll be able to say, is there anybody in the system with this? Is there anybody who wants to be discovered? So we'll be able to ask those questions, and we will be able to make assumptions about data which people have chosen to share with us. But what we won't be able to do is to access anything that people haven't made part of the system.
Haven't made public.
That they haven't made public as part of the system. Yeah. So. No. No, so the model doesn't exist. So we wouldn't be able to send data off on behalf, to anybody else.
Care.data.
We can't do care.data. We can't do care.data because actually this is the architecture which is designed to avoid the state being able to decide to share data that belongs to people. So before your data goes to somebody else, you have to give permission for that data to travel.
So can I put in the social dynamic issue, which is there's a technical thing, which is I've been brought up for the last 10 years, and my kids have been trained not to put login details into a site that doesn't look like the site they think they're accessing. So you kind of go to a different site and you're asked to log in there, and that's, hang on a minute, what's all that about? That's sort of part of it. But there's a broader thing, which is there's the easy, insecure method, and then there's the safe but harder to do method. what are the ways in which we can reduce the risk of putting people off participating by saying, well, you have to go to the site to log in and get a different ID?
So what we're hoping is, and this is one of the things we want people to look at in the UX lab, is that we're smoothing that path so that even if you haven't already got a data store, which obviously we have to assume most people won't, that actually this is an understandable journey and you don't have that disconnect, which I think when you use OAuth, if anybody has, or OpenID, that was always a bit dad at the disco. It was always very it was always very clumsy the way you moved between different spaces. So we're hoping, because we're working directly with MyDex, we're hoping that we're going to be able to smooth that journey and we'll be able to put the explanation in place, which is, this is why we would like you to take this additional step. What we're going to have to test is whether or not, as we test that with more and more people, whether or not people do take the additional test, and whether or not actually that we're at what point in the journey we're losing people at, if we lose them at all.
And just to add something to that, which is, I think the timing of it is very good because it surfs this sort of wave of Cabinet Office pushing out ID assurance. So from later this year, anybody who wants to use a digital public service has to have an external identity assurance provider. There's a choice of 5. MyDex is one of them. And I think having a diversity of useful things you can do at the same time makes that a more comprehensible message. So I think NHS Citizen, surfing analogies and waves, I mean, it's all about timing, isn't it? But it feels to me about right. So people who are registering for a digital identity for a different government service would then be able to connect to NHS Citizen, and suddenly it's the same terms and conditions instead of having to see a different set.
Just to go back a stage, you have to log on with a username and password. Are there any other ways of, I mean, now everybody is sort of getting little things, from their banking systems, and two tokens.
You can start the PDS in the context of a different journey. So the NHS Citizen Service can start your MyDex PDS without a heavy MyDex PDS interaction. And then there's the question, I think this goes back to what Robert was saying about ramping up the access controls so that you do use new technologies. We've certainly tested and run voice biometrics so that you can only access your personal data store by reading out in your voice. And that's a whole huge topic, but it falls into the category of more secure ways of accessing a system, and you can just plug these technologies in as they are appropriate and popular.
So I want to drag us back a little bit to NHS Citizen. Excellent. All right.
First of all, I mean, you've talked about a certain amount of data. Let's say NHS Citizen wants to change what they require. How do you tell your populace to go back into the system and re-input new data? Or how does a citizen remember to update the data?
Well, the individual initiates a connection in which a certain data set is permitted. If more data is required, because there's some new area of inquiry, then that would be a new dialogue and a new permission.
So that would then come back.
Yeah.
But let's say the 20 questions, and I now know. Sorry, let's say the 20 questions, and one of those questions is, am I married? Yes or no? I'm not. But I get married. Yeah. How do I remember to go to my database and update it?
Okay, so
or anything else.
The way we solve that issue is with linked fields. So if you change your address, your phone number, your marital status, your name, or any such thing, these fields are all linked. The first time you need to give the different information, I'm now married, it'll say, do you want all the other linked fields which say whether you're married or not to change as well? And if you say yes, then they're all changed. And so it does make that process a lot more convenient. Well, if you never have to tell anyone you're married, then it doesn't arise. If you do have to tell someone you're married, then you do it, but that also solves all the other instances. You have to do it once. You can't make it 0 times, but once is okay, I think. Yeah.
Which means that there will be, and I'm not saying it's bad, in fact, it's probably very good, means that there will be a consistency on what you're actually claiming. I mean, if you claim that you are 1 foot, 1
1,80 m, 1,80 m, and then the other time you say you are 1,60 m, you're going to raise a flag.
Are you okay? We get on this path. It's quite okay. So
raising a flag is something else, Randy.
Indeed, yes. The market will need to play out the question of self-asserted claims. I mean, you might talk to a shop about buying pyjamas for somebody who's 1,80 m because it's for your nephew or something. But if somebody's going to rely on claims that you're hiring a car and you want to prove you have a driving license, you would want an externally validated proof, and those you can't forge and change. So there will be data. I mean, curiously, when you look at the market valuations of data, the most valuable data in the marketplace, different story.
But take, for example, something like gender, where some people would say, okay, I'm heterosexual, then in another context they might say, oh no, I'm actually bisexual, and in another context they might say, well, no, I'm actually, and I've heard an immense amount of diversity.
Okay, so I think that's a really interesting point. Okay, so one of the reasons that I am very keen in pursuing the data store is that I think that it is a way that you could enable people to present different personas in different contexts. So you could actually allow the same person to be considered themselves to be male in one context and female in another context if they chose to. So actually, because transgender services is a big issue, sort of around, that's a really very excluded group, and you could actually, enable people to actually present the person that they choose to be. So I'm not saying, again, there's a socially, how does that play out? I think we're in very early days with that. But one of the things that digital has done so far is to take us down a path where it's impossible to present different sides of yourself in different contexts. And I'm quite interested in seeing what happens when you allow people to do that. An example for me is around, sort of political leanings and things like that, which is where public servants are not able to have political opinions in public. So actually they're an incredibly disenfranchised group. So if by doing this you were able to allow, you could enable people to have opinions which do differ from the public persona, which is I don't have political opinions. Every civil servant that I know has really strongly held political opinions, and yet they're forced to have a public face, which is I have none. This is, again, another way of being the same person, but actually presenting a slightly different self. So I don't know how that will play out either, but I think it's one of the potentials of giving people control over the information that they present. Ooh, I think it's a really interesting area.
It is indeed. I mean, I was hearing a TED talk about gender, and it's coming out that because now we are so able to find out DNA analysis, the basic difference that we are used to, XX and XY, do not cover at all what we are having. And not only you have XYY, XX, all sorts of others, but then you have people who are maybe XX, but then they do not have the receptors, and then they developed as male or something like that. So I think you'll have to go back to the genotype at some point, and then to how a person perceives itself.
So this sort of relates to the point about kind of like self-reported data versus externally validated data. Is actually gender something you define for yourself, or is it something which is defined externally? And that's a whole philosophical debate, but I think that actually you can argue that gender should be one of the fields which you're self-defining. Now, well, and there's a question between there's two very different trains of thought around that, but it's one area where this question about what data can be self-defined and what data needs to be validated is going to be, this is one of the big debates of the 21st century, I think. So, do you want to?
No, just thinking about the gender thing. I suppose why does it matter? Well, I suppose it matters to do with things like paying pensions and when people are eligible for pensions, the difference between men and women, and how else does it matter?
Well, in medical terms, a lot of actually it does matter because there are some services which are gender specific, for instance. and ward allocations,
Ward allocations,
you know, sort of,
probably do.
and things like
Yes.
that. I mean, it's, you know, there's I think there's an important principle is we shouldn't be interested in any data that isn't useful. Is that I think if we spoke to the NHS England team, they're pretty clear that gender is one of the things that they want to know, but they also want to enable people to self-define it and to be able to change it.
I looked at a GP survey form a couple of days ago, and one of the other questions was sort of ethnicity, and it's a terribly long list, you know. And I could tick 2 or 3 of the boxes, you know. Which one I
don't let us stop you. I mean, I think this is sort of back into this is almost back into a gather conversation, which is that how much do you need to know in order to make a good decision? So in a gather conversation, what of this descriptive information do you need to have in order to know that there's a balanced debate going on?
And also one of the questions that we haven't... Yeah, is he? Okay, all right. One of the things that I think we were talking about in Gather during some of the design conversations we had earlier is what's the concept of standing in Gather? Because you talked about standing meaning something, you know, in relation to a debate. So are we going to give people a sort of check mark for the fact that they are, you know, Regius Professor of Epidemiology in a discussion on epidemiology, but then not on something else that's unrelated to their field? You know, are we?
Speak of gynecology.
No, but not you mustn't speak about it, but a bit like the House of Lords thing. Everyone says, "Oh, isn't it so great that Robert Winston's in the House of Lords?" And I think he's a lovely man, but I don't see why he should be particularly opining on my tax rate rather than, you know, rather than matters of biology. So I think the part of the kind of personal data store, in a way, could be to give some way of showing the standing of someone in the debate, not just the standing by the activities they've done on the site, but the standing by, you know, how verified they are in, you know, on particular levels of expertise. So, sorry, William, do you want to comment on that?
Just to say, that's theoretically possible and very powerful. In the short term, I don't think the Royal Colleges will be issuing those. So, I mean, let's campaign for it, but not hold our breath.
Yeah, I just want to add to, you know, the question of, you know, in terms of what, you know, personal data will be gathered. I know in Icelandic privacy laws, there's a rule which basically says that you should not collect anything except if you really need it, you know, and yeah, it's the same here. So if you need to, so if you're in an audit, then you need to have like really clear path why you took the decision to collect this data.
I think I personally think that we're moving into a really fascinating new world, which is where, you know, sort of where data's gone large. And there's a few things about that. One is that I think we do need to spend some energy rebalancing this so that individuals have control of it. And that's why the personal data store is part of our architecture. But I also think we've got to start to learn how to make decisions on the basis of enough data rather than our trained... the way we've worked for a long time is we've kind of had this assumption we can know all of the information. And so we've been gathering and gathering and adding and adding and adding and asking more and more questions about ethnicity and things like that. But actually, we need to change our attitudes a little bit and say, actually, what's enough data to make a good decision? And that's what kind of we're coming at it more from that angle, because we think that's more achievable, but also it seems less intrusive. Do those 2 points make sense?
Can I ask a technical question? So you talked about ethnicity, exactly. You talked about, you know, ethnicity and so on and so forth. Is it possible to do a kind of cloaked demographic analysis? So rather than give a population and say here's the breakdown of it, rather than actually necessarily identifying one person with one trait.
I'm keeping mine.
I can try to answer. Yes, you can, but then it's actually quite easy to identify the person.
This is the whole pseudonymization kind of thing, which is that what is that? So it is possible if the nature of your data, if the nature of the question that you're asking is pretty broad and your data set is pretty large, then yes, perhaps you can theoretically do that. You can come up with those kind of do that kind of sampling. I mean, and this is actually the issue that the police data services come up with, stuff like that, is actually, and this is the arguments around care.data, is that actually you only start to drill down a little bit into a data set and suddenly actually people become knowable quite quickly. Mainly because we've all been a bit slutty about leaving bits of our identity over the internet. So it may not just be in that data set, but you're able to connect to other data. You know, it only takes 3 or 4 points of connection and suddenly you're into a whole other data set and suddenly you can start to see the whole person. So there's a big question to me is the genie already out of the bottle and do we have to just give up on the idea of privacy and control? And I'm not personally quite ready to give up on privacy and control, but we're going to have to start doing something about it quite quickly. Otherwise, you know, everything about us will be knowable.
I completely support that. Yeah.
Okay, so I'm going to draw because we're kind of we're sort of at the end. I think so. So what I'm hearing is that despite some really useful questions, is that you're happy with this as a direction of travel. It's definitely it's the thing to do. And the questions are, and if everybody could go into the UX lab and start to see how is this actually working in practice, and then your feedback on that would be really valued as well. So thank you very much. Really interesting session. Thank you, William.
Thank you.